I think it's time for the next session with oral presentations called Pearls of Wisdom and Real-Life Indication and Future Perspectives. And our first, I remind you that the presentation should be like 10 minutes and we have time for only one question for each lecture. And I invite Professor Andrada Săicean from Romania.
Good afternoon. Thank you for the introduction. Thank you very much for the invitation, and congratulations for the whole team, especially Paolo and his team, but also Julio and Erwin for these fantastic meetings and very well choices of the cases for this morning. So in the next few minutes, my task today is to talk about elastography. And when we talk about elastography, what we know from, if it's possible to help me. Just a bit. So what we know from our colleagues from percutaneous ultrasound, but from all the possible systems in percutaneous elastography, in US we have only two systems. One of them is about strain elastography and the other is about shear wave elastography. So the first part of my talk will be on these two types of elastography. So strain is what we use every day in our daily practice, and it's provoked by the compression due to the vascularity, to the blood compression, and of course, unfortunately, sometimes too much compression from our transducer. So what we see here is when the tissue is very hard, the compression is not so important, and we see a blue color, and when it's soft, the compression is more important. And we have to take into consideration several aspects and several conditions for having a good elastography procedure. First of all, we have to cover as much as possible for the lesion in our region of interest. And second of all, we have to avoid the softness structures around our lesion, if it's possible, without calcification and without vessels. And there are several possibilities for assessing elastographic image. First of all is what we know as elastography pattern, and this was described first by Giovannini, and now this is an updated aspect of what we know. When it's homogeneous blue or heterogeneous blue is hard and is most likely to be malignant, as in this case of adenocarcinoma, but sometimes we have neuroendocrine tumors which has this aspect. And when it's green and heterogeneous or even homogeneous, then is most likely to be a benign lesion, as in this case of chronic pancreatitis, as you can see here. So the second and the third possibility of assessment, they are semi-quantitative possibilities. First of all is strain ratio, which measures the strain inside the lesion and around the lesion. And this around the part could be here in the neighboring tissue or in the wall gut. And when it's less than 10, it's most likely to have no malignancy. When it's more than 10, it's most likely to be malignant. Another possibility of semi-quantitative assessment is this form of a strain histogram, where we measure every strain inside the selected area. If it's less than 50, this means it's a hard lesion. If it's more than 150, it's a soft lesion. The other possibility is shear wave elastography, It's present on the very modern ultrasound machines, and the principle of this elastography measurement is different from strain, where the compression is in a vertical way. Here, it's the transmission of the waves is measured in the transverse, in a perpendicular system. So as you can see here, this is the way we look for the shear wave propagation. But there are several limitations of this procedure. Although we respect what we know in elastography, it means to avoid cysts, vessels, and calcifications, and we try to do the best penetration depth adapted to our lesion. It's very difficult for this measurement, first of all, because we have to have it very close to the transducer. So if we go deeper, then the measurement is not good. And another problem is that we have to have a stable lesion without movements. This is very difficult in our patients which are not intubated, and we do not stop the respiratory movements. And that's why what we apply in our patients is the end of the expiration, where there is a quite long period of time in these patients. And if you look here, we have a region, we have a region of interest which is fixed 5 to 10 millimeters, and we have to perform several measurements. But in these measurements, what we have to look is, first of all, is reliability index. We learned from our colleagues from percutaneous elastography that this should be over 60. And in our experience, this is very difficult to be done in our patient in the US. And we have two parameters, velocity, which is expressed in meters per second, and E, which is expressed in kilopascals, and these two are always displayed over here. And when we looked into the normal pancreas, you can see in this, it was this measurement in the body, the speed was about 2 meters per second, and in tail it was a bit more, 2.2. So which are the clinical implications of this method? First of all, is important for differentiation of solid pancreatic masses, and this is quite an old but very important paper published by Julio more than 10 years ago, and where you can see that in case of neuroendocrine tumors, the value of the strain ratio is the highest, followed by adenocarcinoma, and then inflammatory mass or normal, which is about 1. And what is very nice to see here, and why I particularly wanted to show it, is that in fact of adenocarcinoma and the neuroendocrine tumor, it's blue, but neuroendocrine tumor, they can have some green patches inside, which means that there is a heterogeneous lesion inside. And in case of autoimmune pancreatitis, what is very important is that the whole gland is blue. And as I will mention a bit later, this could be modified during treatment. In case of metastasis, this could be very, very tricky for us, because we can say it's a soft lesion, but in this situation, you can see it was a metastasis. So when we looked into the literature for the value of elastography, there are several meta-analyses published until now. When they looked for the color pattern in more than 400 patients, they obtained a sensitivity of 98, which is huge. But unfortunately, the sensitivity was only 63. And this was the same in case they used strain histograms and strain ratio. So this is the value, and the main problem is the fact that hard lesions, they are not always adenocarcinoma. But when they looked in very small lesions, because what the problem is that if we have a huge lesion of more than 5 centimeters in diameter, we cannot have all the lesion inside the region of interest. So that's why it would be preferable to have lesions below 3 centimeter in diameter. But even in small lesions, below 15 millimeters, there are two studies, I put here only one of them. The value of elastography is good, with sensitivity of 84, and for malignancy, if they include other tumors apart adenocarcinoma, and for pancreatic cancer is also good. So the main conclusion, and this is very good for the small lesions located in the tail of the pancreas. If this lesion is a green lesion, this ruled out the malignancy. So which one? Pietro will talk about contrast. And there are only few papers comparing the two methods, elastography and contrast. There is a meta-analysis published this year showing that, as you can see, the value of elastography is, as we know, with sensitivity about 90 and specificity about 60 to 50. But contrast performed better in this situation. And if we put them together, the results are better even compared to contrast alone. So that's why we have to use both of these methods in our examinations, although this is not the best selection of articles in this meta-analysis, because two of the contrast studies used power Doppler and not harmonics, and also we have to take into consideration that elastographic is represents a problem in point of view of reproducibility. Is it good elastography to guide our US tissue acquisition? And there are three studies on this aspect. First of all was published several years ago, 5 years ago, and the results were good. We did the second with our group, and we compared Elasto USFNA without and USFNA in a crossover manner in 60 patients, and we noticed no difference between them. And this is a very nice and interesting study. They compared the guidance of hard and the soft part of tumors and no guidance using USFNB. And again, no difference, as you can see here. But what they noticed here, and this was very nicely proved, it was that in case of very hard stroma, there was a correlation with the strain ratio. This is an aspect that we knew before, but the core length of the fragment was not influenced by, was not correlated with strain ratio in these patients. So we cannot do it, and we just have to orientate ourselves to do tissue acquisition, but we cannot do tissue acquisition during elastography. What about difference between shear wave and strain ratio in pancreatic masses? There is only one retrospective study published until now, which showed that there was no difference between lesions like adenocarcinoma and neuroendocrine tumors, and they say that it's not reliable to do strain shear wave elastography because we cannot rely and we cannot have a good VSN. As you can see here, it was only 18%. We tried in a prospective manner and we included more than 90 patients with pancreatic masses. And here we obtained quite the same things. It means that, as you can see here, there was not a very important difference between adenocarcinoma and neuroendocrine tumors, and even the difference from inflammatory masses, although we didn't have enough patients in this last group. So we could not rely on these parameters. But what it was more important in our experience, although we tried and we did more than 10 measures in every patient, we obtained with much difficulty more than 20% VSN in our patients. So that cutoff of 60 is very hard to be reached with these measurements. What about pancreatic fibrosis or diffuse pancreatic diseases? Strain ratio is very good for showing fibrosis, and the first study showed a comparison with surgery. Strain ratio in pancreatic cancer is somewhere around 2, and this was an early study done by Julio. And in case of inconclusive pancreatic chronic pancreatitis, when we don't know if it's chronic pancreatitis or not, again, the strain ratio is about 2, and this is again a new study published from Julio. And what is important, this strain ratio is very reliable if we take into consideration Rosemont criteria for chronic pancreatitis or the number of features, considering here the hardest tissue in concordance with the number of features, and the most recent data published by Julio, which showed that strain ratio is very well correlated with the low bicarbonate secretion in patients with chronic pancreatitis. So we can rely on strain ratio in pancreatic fibrosis. But what about shear wave elastography? There are only 2 studies published on this way, and I will refer on this one, showing that in patients with low excretion, pancreatic excretion, and you can see here in the last row that shear wave elastography performed a bit better with 90 sensitivity compared to strain elastography. So in this study, they showed that it could be reliable shear wave elastography, but again, here you can see in these 2 pictures that there was no correlation for the strain ratio or with the features of chronic pancreatitis. Problems is with shear wave in diffuse pancreatic fibrosis is the fact that we have values, but cutoff values, as you can see here, are very orientative, are not very different, so we don't know the future yet. Considering lymph nodes, we know that blue means malignant, green means that it's more likely to be not malignant, but the sensitivity and specificity are not the best, and even we go for strain ratio, we cannot differentiate very well. So in this situation, according to the actual guidelines, we use elastography for lymph nodes only if we cannot reach them by USFNA, if these lymph nodes are beyond our possibility of performing FNA or FMB.
Sorry for interruption, but we are a bit late.
Okay, so sorry, I will finish in a minute. So first thing is about liver fibrosis. The indication is about patients with obese patients or patients with difficulties in accessing right lobe by percutaneous, and results are important, and they have been published. I will not insist, we will see the next in the future. Other possibility is to see if there is any vascular invasion or to follow up the strain ratio, which decreases in case of corticotherapy for autoimmune pancreatitis. So finally, elastography is promising. It's part of our daily practice. It's good for pancreatic masses differentiation, and shear wave seems to be promising, but only for diffuse diseases in the pancreas. Thank you.
Thank you. Thank you so much for your presentation. We are going to save the questions for the break. And now I'm inviting Professor Fusaroli to present us Contrast Enhanced US.
Let's face it, life is difficult, and clinical life is probably more complicated. I've listed here just a few issues we have to face every day, and we have to do it in the context of very difficult patients getting older and more fragile, and with always agitated parents behind them. relatives. So, and at the same time, we have in our hands very invasive and expensive treatments that we should manage very well. So we need an effective solution which is simple, efficient, and maybe even a single step. And my proposal today is CHEUS. CHEUS is a very simple technique which in a limited time gives you a lot of information, as I have to do today in my talk. So I've tried to list a few of the indications from the very established one, such as the study of pancreatic lesions and lymph nodes, to the realistic subepithelial lesions, differential diagnosis, and guidance to tissue acquisition. Those I've called innovative, predicting tumor prognosis, and finally the experimental related to guidance to therapy and AI. So I don't have the time to cover all those, but let me start with the very established ones. So we all know that a pancreatic ductal adenocarcinoma is black, is hypoenhanced, so this may seem granted, but still, if you carefully think about it, you get a lot of information from this video. Sometimes the tumor is not so easily seen in B mode, and the contrast just brings it up for you. And also, you can have information that are complementary to tissue acquisition when tissue acquisition is inconclusive. On the other hand, if you have a nice hyperenhanced nodule in the pancreas, maybe in a patient who is symptomatic for neuroendocrine symptoms, again, you are very confident that this very brief examination gives you a lot of detail. And last but not least, in solid components of pancreatic cysts, when you see a lot of material inside, and we've seen a beautiful case today, if you see an enhanced nodule, then this patient is ready for surgery because that nodule is malignant. Going to the realistic indications, what we know about tissue guidance. We know from several studies that in terms of FNA guidance, you gain in terms of sensitivity, accuracy, and adequacy of the specimen if you look with contrast first and then put the needle there. We also have studies regarding FMB. In FMB, the results are not so satisfactory. Maybe FMB doesn't need any guidance at all. In this study, the authors randomized the patient to contrast-guided FMB versus non-contrast-guided FMB, and they found no difference whatsoever in a lot of parameters they took into consideration. But still, I think when I see a tumor like this one, and this reminds me the case performed by Mara Petrone today, and the tumor, if you can play the video here for me. Okay, the video is going. And the tumor at B mode and at elastography might seem homogeneous, solid material throughout, but in a few seconds after contrast injection, you start to see that a large part of this tumor is necrotic, is liquid, and you won't get any information if you stick your needle here. So I don't think we need so many meta-analyses to demonstrate that this may bring you some useful information for your tissue acquisition guidance. What is innovative? We can predict the prognosis of a neuroendocrine tumor of the pancreas, and we have many studies showing this issue from a recent review. The study I prefer comes from Japan. They investigated a group of patients with neuroendocrine tumors in the pancreas, both with contrast-enhanced EUS and contrast-enhanced CT scan. And with contrast-enhanced EUS, they got very reliable results, and they were able to distinguish the tumors in aggressive and non-aggressive compared to the enhancement. If the tumor are hypo, or better say heterogeneously enhanced, these tumors are aggressive. If they are hyper-enhanced homogeneously, then these tumors are non-aggressive. And this is an example. This tumor here is heterogeneously enhanced, while this tumor here is homogeneously enhanced. And as you can see in the histology, the cells here are much looser than in the non-aggressive tumor, and you have a lot of stroma, which we know is bad for prognosis. And if we look at this curve, these two tumors, those in the blue line and those in the red line, they are the same at FMB. They are G1, G2 tumors, both groups. But the blue ones are homogeneously enhanced, so we call these non-aggressive, and you can see this in terms of survival. And the red ones have a very shorter survival expectancy. So these are the aggressive. And again, this is an information you get very easily. You can do the same for pancreatic ductal adenocarcinoma. We have carcinomas that are hypoenhanced both in the arterial and in the venous phase. Some are hyper in the arterial and hypo in the venous, and some are hyper both in the arterial and in the venous. And if you look at the survival, those who are hyper in both phases tend to live a little longer and to respond better to therapy as compared to those who are hypo and hypo both in the arterial and venous phase. So what is in the future? Probably AI will come. We have a lot of publication regarding AI in the general field of EUS, and we also have publication regarding AI in CHEUS in particular. This study coming from Romania applied AI to several enhancement techniques of the pancreas. We are interested in CHEUS for the purpose of this talk, and it's impressive what they were able to obtain in these patients who were studied in a training set, which means they fed the system with lesions that were known, and the diagnosis were pancreatic ductal adenocarcinoma, chronic pancreatitis, and neuroendocrine. And then the validation set is tried the system, how it works. And the system worked very well in terms of accuracy, area under the curve, etc., etc. You see all these figures are well above 95%. So we can interrogate the machine asking, what is it? And we get a very reliable response. We can do the same in subepithelial lesions, GISTs versus leiomyomas. Without going into details, we know that AI distinguishes GIST versus leiomyomas comparably to expert endosonographer. Fascinating, depressing, I don't know, I'll let you judge. But for sure, I think we have reached the limit of our research here. If we don't work in a network, AI doesn't mean anything if it's based only on your own cases and if they stay only in your machine. We must find a way to put all us doing this nice and beautiful work, although in a difficult clinical life, together, so we can share our result to come to the real augmentation of our knowledge. Thanks.
Thank you very much, Professor. I'm afraid I'm going to have to invite the last speaker for this session, Professor Adrian Săftoiu from Romania, to tell us something about AI in US.
Thank you very much, and thank you very much for the kind invitation. It's always a pleasure to be here in Milan. And I will try to briefly cover the artificial intelligence field, because we already have seen a lot of imaging methods: grayscale, color Doppler, elastography, contrast enhancement. So it's a bit difficult to understand all of them and to understand how we can place them in the clinical diagnosis. So just briefly, artificial intelligence is basically a software which performs like the brain functions. And from this broad term of artificial intelligence, then the separate term of machine learning was developed. And during the years, we are talking now about deep learning. Deep learning uses complex software programs which use artificial neural networks. Basically, this is a structure of an artificial neural network. It is inspired by the neuroanatomy of the brain. So basically, it has an input layer where you insert, for example, a lot of images, and then you have some hidden layers with some interneuron connections. So it's exactly like the structure of the human brain. And then you have an output layer where you have different diagnostic categories. And if you look at what happened with the cars, you see that the car makers began to drop the terms of self-driving and the mobility because the cars are not exactly autonomous. If you look at Tesla, they are not exactly autonomous. So basically, the other car makers make cars which can drive as long as the drivers are vigilant and nothing weird happens along the way. And you can also appreciate that in Eastern Europe, there was a long experience with autonomous driving before Tesla even appeared on the market. So if you look at endoscopy applications, then there are a lot of applications. The one which is on the market is the detection of colon polyps. This is a nice system from Israel. So if you look at the image, can you spot the polyp? Then you see the artificial intelligence picks the polyp before the human eye can see it. If you go closer, then you clearly see the polyp where it is, and it's actually two polyps in the image. These are called elusive polyps. So those are polyps which are difficult to be seen, or they are staying less than 5 seconds in the visual field. And in some cases, it's even difficult because of the prep. So again, if you have artificial intelligence, you just wash a bit, so we try to clean. So you see that already the system picks up a polyp. And then if you wash more, then you spot a small sessile serrated lesion. So this is how artificial intelligence works. In the colon, there are applications already in the stomach. So this is one Chinese system, and you can see it detects a lesion, then you magnify, you look with NBI, and then it will also characterize the lesion. So you will have both detection and differentiation just to clarify the diagnosis. And this system actually outperformed endoscopists. So even trained endoscopists, you see that the accuracy rates are better for the diagnosis of early gastric cancer. Then moving to ultrasound, there are a lot of applications which are under development, including statosis, including focal liver masses, breast, thyroid, prostate, and also pancreas. And this is a paper published in gastrointestinal endoscopy. So it's basically a training system which shows you the different stations. So once you start the examination, it looks at the position of the endoscope in the stomach or the duodenum. And then you switch to the US image, and then it picks up, for example, this one is the normal pancreas in the station 2. So then you have to go station by station to have a structure examination and to see the pancreas head and the pancreas body and the pancreas tail. And it also depicts the vessels. So it does some sort of segmentation. You can also look at screening. You can use artificial intelligence for screening purposes. So, for example, in patients with new onset diabetes, which have an increase of the risk of pancreatic cancer, and there are systems which use artificial intelligence-assisted risk analysis. We have used this some years ago with the basic model of artificial neural networks for elastography, because we thought at that time that elastography images are difficult to be characterized. So we have published this in both a single center and then in a multi-center trial. And actually, an artificial neural network had a better accuracy for the differentiation of normal pancreas, chronic pancreatitis, and pancreatic cancer. Then you can also look at contrast, and this is again data from our multicentric trial of quantitative dynamic contrast harmonic imaging analysis in a multicentric trial. And again, using artificial neural networks, you get a better accuracy for the diagnosis. And Pietro already showed our work using multiparametric US imaging. So if you combine grayscale, color Doppler, contrast, elastography in a single model, software model, you can obtain an accuracy of around 95%. So we know this already from the artificial neural network models. They won't reach 100%. If you have a model which will differentiate cats and dogs, for example, it will reach an accuracy of about 95%, not more than that. So, but you can reach an accuracy of around 95%. You can use AI for complex systems like fusion systems. This is an example of a fusion in between EUS and CT or MR. And you can use artificial intelligence to guide you in this kind of complex system. And artificial intelligence probably will be used in therapy monitoring. If you are performing organoid research, then it's pretty difficult to choose the right chemotherapy unless you use this kind of system. And it has been used already. This is a nice paper published in Nature 2 years ago on real-time pathology. You see, again, the accuracy of an AI-assisted system is around 94%. It's a system for Japan which can detect automatically adenocarcinoma in fine needle biopsy specimens. Then looking at our work, this was our team. It has been published last year in PLOS One. We have looked at focal pancreatic masses, and you see an example on the left side. So this is a tumor. This is the normal pancreas. You can easily see the difference. Again, what we have used, we have trained an artificial neural network for this. So basically, we use this, this kind of masking. So each image has to be individually segmented, and then a network can be trained, and it will recognize newer images, and it will also give you the accuracy of the diagnosis, so the prediction here. So you can see this is a solid tumor, and you get also the prediction here. This is the pancreas, and it will give you the prediction. Of course, you can use multiparametric EUS, and this is important because we know already how the diseases look like. So chronic pseudotumoral pancreatitis is hypoechoic. It's hyperenhanced during low MI contrast harmonic imaging or color Doppler, and it has intermediate stiffness with elastography. If you look at a neuroendocrine tumor, it's again hypoechoic in grayscale. It's hyperenhanced with contrast enhancement or Doppler, and it has a high stiffness with elastography. And if you look at adenocarcinoma, again, it's hypoechoic, it's hypoenhanced, so it's hypovascular in both contrast enhancement and color Doppler, and it has a high stiffness in real-time elastography. So combining all these parameters in the convolutional neural network architecture, of course, the architecture has to be complex because you're looking at different types of images, and each one of them has to be treated separately. But you finally get an output, and you can classify chronic pseudotumoral pancreatitis, neuroendocrine tumors, and adenocarcinoma. I don't want to get into the details, but after training the network, you reach an accuracy of 96%, and this is how it can look in real time. So now you see a model of a convolutional neural network looking at the pancreas. So you see it works in real time. You can nicely see the pancreas, but suddenly you see something here, something else. So it spots a small tumor here. Again, it gives you the prediction in real time, so this is how it works. So for the doctors which are, let's say, not familiar with this kind of images, it always picks the pancreas, and it picks also the tumor. So you have to search for the tumors, for the tumor in different section, but this is how it looks in real time. So you see again here, normal pancreas, and the tumor here nearby the splenic artery and splenic vein. So coming back to the movie, if you prolong a bit the examination, you will see the tumor showing up. Now you see it again, so you have to be stable on the tumor, and you see the prediction rate is pretty high, so it's above 70, 80, 90% in various images. And then you can also do fine needle aspiration biopsy in real time using artificial intelligence as a guidance. Of course, this is done with the usual laptops. If you use a graphic station, you can increase a lot the computing power. So you can do a lot of things, and you can see here the fine needle biopsy, and you see that the system works in real time. It picks up the tumor and the tumor moving with the needle inside. So this will probably be the, let's say, the next generation US. We have seen the young doctors in the next generation session at the beginning of the conference, but we will have to wait for this kind of systems, which will probably show up in the future. And if you want more details, I would like to kindly invite you to Florida in August during the next Live US at Orlando Digestive Health Institute, where we will see if the technology progresses in real time. Thank you very much for your attention.
Thank you very much, Professor, for your presentation. I think we are going to pass to the live cases, and I invite the next moderators for the next session.
Thank you very much. Here we are back from HPB unit in San Raffaele. As we have connected India in the previous sessions, now we move to another part of Europe, and it's my privilege and to present and to introduce the next connection with the University of Leuven, with Professor Schalk van der Merwe, who is waiting for us. Thank you, Schalk. Schalk, can you hear me?
Yes, I can. Can you hear me, Paulo?
Great, great. Thank you very much for joining us, and thank you for being patient to wait for us for the connection. So please go ahead and present your case. Thank you very much again.
Thank you, Paulo. Yes, the case that we want to present will be a lady that is 72 years old that presented 4 weeks ago without any prior medical history. She presented with vomiting as a first symptom. Because the vomiting became intractable, she was further worked out, and it turned out to be a malignant gastric outlet obstruction at the level of D2 that was caused likely by a periampullary tumor. I don't know if you can see my slides, if you can see the images. The first, if we can move to the second slide showing that image, you can see that she unfortunately has liver metastases, and due to that she's not resectable. She was also included in the eating trial, randomized controlled trial where we evaluate the benefit of surgery, laparoscopic gastroenterostomy compared to EUS-guided gastroenterostomy. And subsequently she became jaundiced about 10 days after the drainage of the stomach. So that the intention today is to perform a hepatogastrostomy. The reason for that is that previous studies performed with the LAMS group, the Leuven, Amsterdam, and the Milan group showed that there is benefit. If you go to the next slide, that there is the patients that will do the worst will be patients where an endoscopic stent was placed compared to in combination with choledochal duodenostomy. And if you go to the next slide, where the patients that will do the best will be patients that undergo a surgical gastroenterostomy in combination with a hepatogastrostomy. So I think in this case that will be the ideal palliation. So in the room today I have Professor Anna van Marlenstein. She is a pathologist and an interventional endoscopist in our unit with our two excellent nurses, Tamara and Eva, that will join us. Our patient is already intubated, and Hannah already has in view for you the liver and the intrahepatic bile ducts that are dilated. I'm going to give over the microphone to Hannah to take you through the case.
Yeah, good afternoon. So we're looking at the EUS image, the left liver lobe, and we see clearly that the bile ducts are dilated. There's also probably a metastasis present here, as you can see. So there are several considerations when we choose our best position to perform the hepatogastrostomy. This is malignant disease, and we want to drain towards the stomach. So we will use a partially covered stent that is dedicated actually for this kind of procedures. So what we want is that there is some space between the bile duct and the stomach, so that there's sufficient liver parenchyma to land our stent. Of course, we will have a look at the blood vessels, and we don't want to puncture metastasis. So here, I think we have a good position.
I think if you can see, as Anna is pointing out, the bile duct is dilated. There seems to be a window coming from the left to be able to enter the bile duct and advance the needle. So Hannah, what type of needle will you use in this setting?
So we will get a 19 gauge needle. We use a Cook Echo tip needle, and we flush it already with contrast, and we also mount
while Hannah is introducing the needle, there are three ways when you advance the needle tip into the dilated bile duct. The first is to advance the needle and inject contrast to confirm your position. The second is that, especially if you start off doing this procedure, I think that is very worthwhile doing, to aspirate. And the third is to just advance your guide wire without injecting any contrast. And I think that is certainly an option, especially if you are concerned about potential seeding. So in this case, one can see that the sheath of the 19 gauge needle is protruding there, and Hannah will, under careful control, advance the needle into the dilated duct, avoiding the blood vessels. So she has to be careful, just aiming between two vessels.
Just get the best position. It's a little bit too.
Schalk?
Yes.
Can you hear me? Are you using a 19 gauge needle? Are you?
We are using a 19 gauge needle, 19 yes. Gauge.
Oh, yeah. Do you, is that a standard needle or the access to play with the guide wire?
This is a standard needle that we use. I think that we are very used to using this needle, and the reason for that is because of the fact that with the access needle, it is sometimes too floppy. And we have some problems with it. Anna's just going to reposition. It's sometimes too floppy, so I prefer using the standard 90 gauge needle.
Yeah, and no higher risk of shearing than the guide wire when you're playing into.
No, you know what? We use the VisiGlide guide wire, which is a monofilament wire with a very low risk of shearing, and I think if you use that, then it's normally okay. It's normally perfectly safe.
Yeah,
okay, thank you.
But you're right. One needs to be careful with the. I think Anna is in a reasonable position. You can see that it's deviating a bit.
Yeah, it's deviating a bit.
Yes, beautiful. A little bit deeper. Perfect. Now one can see that I think Hannah should be in a good position. If she pulls back a bit, there I think the needle tip is in the duct. And now we will aspirate. This will give us further confirmation. As you can see, bile is flowing back.
So you can see that it confirms our position.
So that confirms that we're in a good position. I think this is worthwhile if you start with this procedure to follow this trick. And now Eva will inject contrast. That will help us to identify the anatomy. We're not going to over-inject contrast.
Okay.
That is okay, because we want to confirm that we're in a good position. We may inject a little bit of contrast later on. I'm just going to need to hold this in position a bit. So I think that the next step would be, Anna, if you...
Yeah, so now we will advance our guide wire. So as we said, we use this VisiGlide wire. And we try to advance the wire really well intrahepatically. So we look at the fluoroscopic image.
I think if you can also comment, Anna, because maybe it's time to take a fluoroscopic image that can can be used as a reference. We will stress this point later on, because this is important when you deploy the stent, that you have a reference image to know where the bile duct and the hepatic parenchyma where they meet.
Yeah, we can put this as a reference already.
And hello, Professor van der Merwe. Hi, Michiel. I'm Cecilia Binda from the audience. I have a question. So, do you always look for the third segment or for the second segment while you're choosing your intrahepatic bile duct?
I think that's actually a very, very good question. And I think it all depends on what the objective is. Sometimes it is better because of the angle of segment 3 to target segment 3. And sometimes you simply don't have a choice and you have to go for segment 2. So it is not always up to you, but it also depends. In this case, you want the angle to introduce your stent and that there's enough space and that it doesn't interfere, because sometimes if the angle is too acute, it's very difficult to perform an antegrade stent placement. But you're right, I think it's about the best position. Sometimes you can only see bile ducts from the esophagus that you want to avoid. So it's a very good question. But as you can see, Hannah has now advanced the wire deep into the common bile duct, probably up to the level of the tumor.
Yeah, you can decide to advance the wire into the duodenum. Here we want to drain towards the stomach, so I think I can just leave it like that. We have some curls inside the common bile duct, so we have enough wire inside and we can proceed.
So I think the principle of bile duct drainage is that there are three ways for us to drain the bile duct. The first is the choledochoduodenostomy, which I think is now very much in vogue. I am concerned with the choledochoduodenostomy because of the risk of cholangitis, and especially in this patient. The other potential technique is the antegrade stenting, which I still find very useful, because if you can place your stent across the stenosis into the small bowel, if there is an obstruction, you can always use the hepaticogastrostomy route as a second option later on. And then the hepaticogastrostomy, which I think has been shown to be very, very valuable, especially in this setting where you have a gastric outlet obstruction, so you want to avoid any stent placement at the level of the papilla. So now the needle has been removed.
So the next step is that we create a trajectory with our cystotome. You already explained that we have it in Europe. It's a 6 French cystotome from Endoflex. And it's very useful to create the trajectory. I look at my EOS image to stay in line with my wire. And again, as we just took the reference image, it's important to see where you enter the bile duct. And also when we use our cystotome, we will look where we enter the bile duct. I think now it's very easy to see that in the middle of the spine, we enter the bile duct.
That's extremely important for placement, because that is where we will aim to release the uncovered part of the stent at that level. But first, Anna will now create a fistulous track using the 6 French cystotome. I think this is so much easier than having to do this with dilator balloons or rigid dilators. It's so much more safe as well. So this is... we're very lucky in Europe to have access to this. We use a setting, comparable setting to ERCP.
So you're not using a pure cut engine. Do you also have coagulation?
Yes, we use a ERCP combined coagulation pure cut setting. There you can see that Hannah has now advanced very skillfully the cystotome into the common bile duct, into the distal common bile duct, and she can, if she wishes to, give a little bit more contrast to define the anatomy. We try to be very restrictive with contrast, but I think it will be okay if we can just show you. So I think that's the level of the
cystic duct. Yeah.
cystic
Yeah,
duct.
that's okay.
And you can see that it's dilated up to the level of the papilla. So this is a periampullary carcinoma, and that is what you expect. If we wanted to proceed to do a antegrade stent placement, we would now have used the cystotome, position it at the level of the tumor, and advance the guideway into the small bowel. But because the decision was made to perform a hepatogastrostomy, that will be now the next step.
So I'll hold here. I think this will be the position where I enter the bile duct. So the non-covered part of my partially covered stent will have to land there, and then I still have some liver parenchyma for the rest of the stent. Okay, kom terug.
Very good. So now the final step is the placement. As already alluded to, we will use the Guilbault stent, developed by Mark Giovannini. And the purpose of the Guilbault stent in this case would be to prevent cutting off side branches by placing the uncovered part in the bile duct and the covered part that will traverse the liver parenchyma and the stomach as to prevent leakage of bile. So Hanna will now show you the introduction of the stent, where we will position the stent, and specifically I want you then to focus on the radiopark marker that will be the transition between covered and uncovered, because that needs to be placed perfectly to avoid that you place it either too far down the bile duct or too far down the hepatic parenchyma and risk leakage.
Any suggestion on how to choose the length of the stent, 8 centimeter, 10 centimeters? Because there are studies that told that probably 2 centimeter, at least in the stomach, are probably better. So which is your indication?
I agree. I think we are hamstrung by the fact that the stent length is 10 or 8 centimeters. So that's really the two options that we have. In the setting of you want, as you correctly state, you want at least 2 centimeters in the stomach, because this is an uncovered stent, partially uncovered. The risk of migration in the stent is low, but the risk of stent misplacement is high. So you will see now, as Hanna places it, she will start pulling back on the endoscope to make sure that she stretches the stent in the stomach, because if you're just going to push the stent forward during deployment, you may end up pushing the stent through the gastric wall. You won't know that from just looking at the fluoroscopic image, and then you may end up having a misplacement. If the stent is too long, we can always go back and trim the stent with argon. So that is not a big concern to us.
Okay.
So I think that, Hanna, will you take it further? I think you're in a good position. Maybe you can pull back a little bit.
Yeah, exactly. So I first advance it, and now I take it back a little bit. And the marker is now at the position where I want it to land. So
so you should have on your screens 2 images, the fluoroscopic reference image where the needle is entering into the duct. And you should have the actual stent now in place, and you will see that it matches exactly the level where the needle has entered into the, and Hanna will make sure. So Eva, our nurse, will start to deploy the stent, and until she reaches that endoscopic marker. As soon as that happens, Hanna will push back. Hanna will pull back on the endoscope. That's perfect. Stop. Okay. So that's absolutely perfect. Now Hanna can pull back carefully on the endoscope and make sure that she stretches the stent so that the stent opens in the stomach and not outside of the stomach by just simply pushing. So as she pulls gently, maybe a little bit more even, the stent is further deployed by Eva, and even if it is deployed within the, pull back, yes, you can see, even if it is deployed within the endoscope, that's absolutely fine. Perfect. Perfect. Excellent. And there the stent placement, we can see there's no doubt that the stent is in the stomach. Anna will just push it forward and Eva will retract the wire and then the procedure is done.
Very nice demonstration. Thank you. It was very nicely show how this technique seems so easy in expert hands, although it isn't so. And I have a question. Usually, once you have deployed a stent, you leave the guide wire for something else, or?
Well, it depends. If you're in this case, we were really sure that the position was good, that we have enough proportion within the stomach. So I took out the wire. If you're in doubt, it's your lifeline. So you keep it in and you're able to place, for example, a plastic stent, a double pictive or something over the wire. But in this case, it was clearly well positioned, so we took it out.
But I think the demonstration, Anna's demonstration was excellent about pulling back on that stent, making sure, because you should not have a malplacement if you pull back enough. I think that is the biggest trick that we can teach you today is pull back on the stent, make sure that it opens up. You can see the stent is fairly long. It's not a problem. We, if need be, we will trim the stent in the coming months and make sure that it's not going to be a hassle.
Galk?
Yes.
Anna, thank you very much for this fantastic demonstration. Thank you very much. So now we move back to Milan and we will see you very, very soon. Thank you very much again and congratulations. We go for the next case.
The following case is about a man of 31-year-old. On February 2022, during follow-up of renal cyst in central findings of 2 pancreatic tail lesions, he underwent USFNA with diagnosis of NETG1. On May 2022, the patient underwent distal laparoscopic splenopancreasectomy, complicated by symptomatic postoperative fluid collection, sustained by pancreatic fistula that was treated by percutaneous drainage with clinical benefit. Follow-up CT scan showed underwent on December 2022, demonstrated a fluid collection extending from the splenopancreatic lodge to the pancreatic resection margin, about 19 millimeters in maximum size. At the time, the patient was completely asymptomatic. On February 2023, the patient underwent MRI plus MCP that confirmed the fluid collation of stable dimension, and the review of the cholangiographic sequences raised the question about Wirsung disruption. At the same time, the patient started to complain dyspeptic symptoms, early satiety associated with postprandial epigastric pain. This is the MCP image of the collection. Today's procedure is a guided peripancreatic fluid collection drainage performed by Prof. Santo from Tel Aviv and Prof. Noya from Santiago de Compostela.
Erwin, can you hear me?
Hey, yes, good afternoon, everybody.
So, good afternoon, you're online.
We are...
Go ahead.
Yeah, okay, so I have as my partner here, Jose, and a very big group, Vito, Daniele, Giuseppe, Zinerva. It's a fantastic group standing by my side, holding my hands. And as you heard, this is a patient after distal pancreatic resection with a fluid collection that occurs about 30% of the cases. And we already have demonstrated and seen the collection. You can see it here very nicely. I must say that it's not exactly the clear fluid collection that we usually see after a surgical procedure. It's very dense, as you can see. It has some particles inside as well. You can see very nicely. But I'm being told that there are no signs of infection. So there was a short discussion how we should proceed. Should we, because we have the possibility to insert 2 plastic stents, or proceed with hot axios? In this case, there is no doubt that there is a pancreatic duct disruption because the patient had surgery, so for sure, maybe he will need a long-term drainage. So practically speaking, maybe the two pigtails would be a better solution. But I recognize that in normal conditions, we would use an Axios and exchange them for a Solus. But I think it's important also to see how things were done the old way, so it's perfect. Jose is the new way, I am the old way. So everybody gets its own share. So we already measured the cyst. The cyst is like 5 centimeters in diameter, and the wall is less than half centimeter. We were looking here for blood vessels, which is a necessary step to see if we have some blood vessels just in the area where we are going to puncture on the right side. The needle will be coming from the right side of the picture. And the procedure will be like this. We will use a cystotome to access the cyst. I don't know how many of you are familiar with this accessory. Can we focus on this accessory? The cystotome consists of 2 parts. It has an internal needle, and it has a diathermic ring. Okay, we access the cyst with the needle, then we go with the diathermic ring, and we can aspirate fluid, we can insert a guide wire, and continue the procedure over that guide wire. There are some people who prefer to do it with an 18-gauge needle first, insert the guide wire, and continue after that. I think it's a waste of money because we can do it one step with this one.
But I have also to mention that it's very important for any endoscopist that is dedicated to interventional US procedures. We are in the age of the lumina posing metal stents, but it's mandatory to know all the previous steps, an additional of the placement of double plastic stents, dilation with balloons. So all that steps are also important to know for any that is dedicated to this. So it's a good thing to put plastic stents.
So there was a vessel somewhere up there. Now we are okay, I think. And we will proceed with the cystotome. The needle is just at the tip of the diathermic ring.
This is a cystotome of 10 French.
It's a cystotome produced by Cook, 10 French. I'm using the Olympus system for this procedure.
In this case, which type of setting are you using
you
for
can
the
see
cystotome?
Beg your pardon, I didn't hear the question.
Which type of setting are you using for the cystostome? Is just a pure cut or you have some coagulation as
yes, we are using pure cut. We are using pure cut. We would like as little coagulation as possible here. So you see on the right side of the picture that we already have the cystotome tip. Can you just gently push forward the needle a little bit, just a little bit? You see the needle is coming?
Yes.
Okay. So now we will do actually the puncture. I'll try to go perpendicular. And now push, please. Okay, we access the cyst, okay. You see the needle is inside already. And now we move the diathermy to the other point. It has 2 points. This is the diathermic ring point. And now I will come with the diathermic ring. Okay. We are inside. We are inside the cyst. Now we can remove the needle, of course. You go, you leave the catheter. You see the catheter very clearly. And we can aspirate fluid just to see how it looks like, if it's infected. But can you show, please, to the audience how this, not too much?
No, not so much.
Not too much, yeah? Yeah, I need some fluid.
Yes.
There. Okay. You are all enthusiastic here, but...
Okay.
Oh, yeah, okay. So it's a little bit turbid fluid, but it doesn't look infected. So the next step will be a guide wire. As you can see, we do all this. The question was whether we need X-rays. So I know that the local practice here is to use X-rays. I've been doing these procedures for forever without. I think, Jose, you as well? No?
Yes, I use X-ray for supporting the procedure, but I understand that it's not completely needed to use it.
Okay, you can see the guide wire very nicely. I can show it to you. Now the guide wire is coming. We do like 2-3 coils in the assist. We just go a little bit more. Okay. You see the guide? You see the guide? And I think it's enough. I think it's enough. So now we exchange, huh? So I slowly withdraw. You push and I withdraw. And now, okay. So just a second, I would like to see the access. It's not always so, but you see the guide. You see the guide on the right side of the picture. And it's very important not to move, huh? Not to move here too much, too many movements, not to lose access. It's very easy to do that. And we are exchanging the cystotome. And we will proceed with the balloon.
So you are dilating the fistulous tract in order to have the space to put 2 double pigtails.
Okay, we are here.
Yes, we are going to dilate with a balloon of 6-8 millimeters. Or
we are going to dilate with a balloon up to 1 centimeter, 8 to 10. It's enough. Thank you. And then we will insert the 2 pigtail stents. Now the balloon is coming. I hope the patient got, I don't know what is your practice, but usually I give antibiotics, prophylactic antibiotics to the patient during the procedure. Cephalosporin, or what do you give? What is the local practice?
Erwin, are you planning to place 2 7 French double pigtail stents?
Yes.
And would you want to put 1 guide wire or 2 guide wires?
No, I will put, because I'm placing big stents, 10 French stents, then I'll go 1 by 1. It's possible to, if you put 2 7 French, for example, then you can do 2 guide wires, but I usually like to put from the very beginning 10 French stents, and then it's okay. We are coming with the balloon.
And you don't use in any time endoscopic view to see the balloon?
I'm trying to use the endoscopic view now at this moment, but I'm trying also to be careful not to lose the, of course, there is a lot of fluid now coming. So the balloon is there. You see the opening, huh?
Yeah. I will call.
It's some kind of opening, yeah. Okay, here we are. I think we are deep inside, huh? Yes, too deep inside. So now you can move a little bit. Okay, the balloon is here. I just remove a little bit. And now you can inflate.
Can we have the endoscopic image?
8 millimeter now. We go slowly. Then go on. Then go on to 1 centimeter.
Endoscopic image.
Okay, thank you.
Okay. It's 9. Okay. So we are on 10 now.
So may I ask you a question? Now you are supposed to be in, but you don't see if you are in with the balloon, and you don't have any control by X-ray. So this is why we usually prefer to have X-ray, because it's like the Linus blanket, you know? It's something that is you can trust on. I know that you are in, but at this moment we don't have any possibility to say that we are really in.
Yeah, but we have the guide wire coiled in the cyst at least three times. We are on the guide wire for sure. Now, when you deflate the balloon,
I think that in this case is the message that we must give to the audience is that you should be sure to be in every single situation of your technique. So I think that having the X-ray in an operating room where you perform this kind of procedure is mandatory. Then you can do the procedure without any X-ray, but X-ray is mandatory. This is what we need, what we must say and tell to the auditorium and to the young endosonographer and the young HPB endoscopy guys who perform this kind of techniques. You should be sure in every single step of your procedure. Then you are, a top expert, and then you can do that. But guys, if you perform this kind of procedure, please use the X-ray.
Okay, now we see the cyst.
Yep.
And now we are following with the 10 French pigtail system, Solus system by Cook, which is a one-step system.
And I have a question for Erwin. Is there a specific time to remove the stents after the drainage? Or depends on the evolution of the collection, or?
Just a second. Can we come a little bit closer with the stent a little bit? Because the cyst is not so big, so we have to. Okay, and then come to me. Okay,
Which
this
could
is
be
very
in
important.
this part of the procedure.
The manipulation. Yeah, the question was if we. How long we should leave these stents? Just a second. The stents in place.
Yes.
So actually, because we are dealing with a disrupted duct, I think we should leave them in place indefinitely. So as shown by Jacques Devier's work and also from our experience, this is the way to go.
Okay.
And what about the risk of leakage in this part of the procedure?
The risk of bleeding.
The
risk of bleeding?
Leakage and bleeding in this part of the procedures. So you have the fistulous tract, and then it's, as we see, there's flowing out of the liquid content of the cyst. So are you confident, you don't have any fear about it, the risk of liquid getting outside, as you don't have a mature fistulous tract?
Just a second.
Yeah.
Just a second. We have to be very careful here, see where we are. Okay, here we are. You see now that we are getting into the cyst. Okay, now the stent is coming. So this stent, we put a mark in the middle of the stent so we will know when we are deploying. This is the first mark of the pigtail, and this is the mark that was done by us. Just to see now we are deploying. Okay, so now I think you can remove everything, yes. One of the problems is, of course, that the migration of the stent into the into the cyst, which we really don't want that. And I'm pushing now the pigtail outside, so the pigtail is done. So we have now, you see, can you see the endoscopic view?
Yes.
Yes.
So we have now one pigtail in place.
Thank you very much, Erwin. A very, very nice demonstration. Maybe you are going to put another stand, but we move to the other room to present the next case. Thank you very much for the great job.
Thank you.
A 59 years old male patient who underwent in 2013 a surgical enucleation of a renal cell carcinoma and then developed pulmonary sarcoidosis medically treated. During a routinary abdominal ultrasound examination, were detected at least 4 hypoechoic lesions of the pancreatic body, and then a CT scan contrast enhanced was performed and found at least 4 nodules of the pancreatic body, head and uncinate process. The largest of one measures about 33 millimeters with a rapid contrast enhancement in the arterial phase. A following PET CT scan with gallium was negative. So today's procedure is US with fine needle aspiration, and the operators are Dr. Sechan from Romania and Dr. Dietrich from Germany.
Another, can you hear us?
Yes, hello.
Yeah, welcome.
Hello.
Good afternoon.
It's a pleasure to be here with Professor Dietrich and a wonderful team. And we are facing a patient with a history of renal carcinoma and with multiple lesions seen on CT scan. So until now, we have seen in the UCNAT processes 2 lesions, one of 2 centimeters and the other one of about 7 millimeters, and we go back, as you can see here, and we will try to show you very nice images as we have seen before. So, Professor Dietrich?
Yeah, so we are very much interested also from the clinical point of view, what has been the histology of the renal cell carcinoma? Because right now, our pretest probability, whenever we have multiple lesions in the pancreas, and we have a metachronic past medical history, it is highly probably that those lesions are renal cell carcinoma metastasis. And those lesions are typically hypervascular and sometimes softer than the surrounding pancreatic parenchyma. As an exception for malignancy in the pancreas. Is that true?
Yes, of course.
And you nicely depict the vessels.
Yes.
And what we can try to get even signals of those vessels, and we can see the resistive index. That means the less diastolic flow, the higher the malignancy. And the more right now, quite nicely shown, we have significant diastolic flow in that patient, and he seems not to have too many symptoms, if I understand well. PET is negative. That's also something important. We have hypervascular lesions, and then why don't we look step by step as you do for the pancreas and later on decide where to puncture the larger one. Is that true?
Yes, this is the largest one.
And for the larger one, perhaps we also apply before the biopsy contrast to be sure not to put our needle into a necrosis or somewhat else.
So you can see here, let's measure it if you agree.
Sure.
Yes. Yes, please.
So
this is hypoechoic, it is non-homogeneous. This is the largest lesion, which is almost more than 3 centimeters in diameter. It's hypervascularized, as you described before.
So we go up to almost 4 centimeters. Those lesions, renal cell carcinoma, are angioinvasive. Whenever we examine a renal cell carcinoma itself, we look for thrombosis and neoplastic infiltration of renal vessel, and they determine the stage of the renal cell carcinoma. And it might happen also in metastasis of there has been you have been
here,
very
yes.
nicely looking to that lesion over here. What Professor Saikan already did is she increased the frequency to a high level and the dynamic range to a high level to get such images of that lesion. And the next step, we are interested if this angio-invasion is neoplastic or appositional. So we perform contrast-enhanced ultrasound if you and we agree. And that means we turn on the contrast mode, the wideband harmonic imaging, and we would be prepared. And you tell us if when you are ready. You are ready?
What mechanical index do you prefer for
it
such
depends on the
situations?
machine, and therefore we have to rely on the recommendations of our experts. And right now,
we try to maintain the lesion in the same position.
And now, if we look for that lesion in B mode, we can clearly see that this lesion is enhancing. So it's a neoplastic. It's a neoplastic angio-invasion of typically renal cell carcinoma, but it might be something different as well from oncological point of view. Therefore, we have to perform perform the biopsy. Is that true?
Yes. But should we go to the next lesion, which is the largest lesion, if you agree?
Sure.
Can we say something about the washout of renal cell carcinoma?
The washout, we have to differentiate two issues. If we look for the renal, the kidney itself, the washout plays a big role and is related to malignancy, to the grade of malignancy. Here in endoscopic ultrasound, we have a different, higher frequency. We have different machines. We cannot compare too much against each other. So the washout does not play such a big role for endoscopic ultrasound compared to transcutaneous ultrasound. So it is somewhat interesting, but there is no correlation, there is no prognosis, overall survival or something which we really can measure and helps us as additional benefit. What do you think?
I agree with you, and I would go for elasto if you agree. If you can help me, please. We should have the whole image. It's very nice. It's mostly green.
You remember that study which was indicated from your presentation by Igne and our group, and it was nicely shown that renal cell carcinoma might be the only or one of those rare malignant lesions which are softer compared to the surrounding pancreatic parenchyma. So that's one take-home message. Almost all other malignancies are stiffer, except renal cell carcinoma, which we
Can we go for a strain histogram or strain ratio?
I don't use it at all because it doesn't help me. I'm interested if a lesion is soft and if a lesion is stiffer. That makes the difference between compression elastography and shear wave elastography. Shear wave elastography is for diffuse processes, and compression elastography shows there's something stiffer or softer.
Would you go for the larger lesion, the 4 centimeter lesion, or the smaller but yet significantly large 2 centimeter lesion, and why?
I would go for the best benefit and risk ratio. And if the largest lesion has somewhat always vessels and perfusion in all that lesion part, then it is easy to perform the biopsy with the best target. So the larger one, the better to get, or that would be my argumentation. Okay. So I would go for the larger one if everything is perfused. Therefore, we would use quite nicely at this moment contrast.
Andrada, Christophe, so go ahead and perform the biopsy. Which kind of needle are you going to use?
It's the FMB Shark 4. What I wanted to show you here is the vascularity, the low flow vascularization inside. It's very nicely seen in such situations. As you can see, it's in the periphery of the lesion. It's typical for this dual DFI system.
Yeah. It's really when art meets science. Yeah. So this is something really, art.
So good. Okay.
So let's go for the biopsy. Thank you.
So we use
it's a shark needle.
It's very, very intense vascularization over there. We advance a bit the needle. It's very soft. I feel it very soft. And let's go for slow pull and a bit fanning.
As mentioned, I made a short video of that soft tissue just to show elastography is feasible and to do it.
Andrada, Christophe, thank you very much for this fantastic demonstration. I think that we will perform another passage for the Vivascope afterwards, but then we move again to Leuven University Hospital because Professor van der Merwe is waiting for us to perform another very interesting case. Skalk? Oh, hello, Mikkel. The big team is here, so thank you very much for joining us as well. You're online.
Thank you. So we did a quick swap to our next patient, and if we can show the slides, please. This is a 42-year-old patient with a history of alcoholic chronic pancreatitis, and he has been suffering some progressive recurrent bouts of pancreatitis. As you can see on the slide,
Go to the next slide, please.
Our MRIs show a progressive pancreatic duct dilation. And at the last MRI, we also see a stricture in the pancreatic head with the progressive PD dilation. And if we go to the next slide, there was already an attempt at a retrograde drainage by an external colleague, which failed. The guide wire ended up several times through a ductal disruption in a collection. And the goal today would be to do a EUS-guided rendezvous. We already evaluated our data, which we're now trying to publish. We did over almost 80 procedures of EUS guided pancreatic duct drainage. And what we see is that the technical and clinical success are quite high. The overall cohort, we have a technical success of over 90%. And we also compared the outcomes of minor versus major papilla rendezvous. And what we see is that the outcomes are almost similar. But our clinical outcomes are even a little bit better through the minor papilla. So the goal will be here today to do a transgastric rendezvous through either the minor or major papilla. And let's have a look at the EUS image.
So what you can see is that this is a clear presentation of a patient with chronic pancreatitis with ductal dilation. If I rotate the scope, you can see that the duct is about 3 to 4 millimeters dilated. It contains intrahepatic calcification, so stones, intrahepatic bile duct stones. And what we have been doing the last years is not only to drain by placement of a stent, but also to completely remove all intraductal stones by following up this procedure with spyglass. And we are awaiting the results, but we think that the results are better in this way as you get complete ductal clearance. So you can see the needle, sheath of the needle protruding. This is again a 19-gauge needle with a VisiGlide, 19-gauge Cook needle with a VisiGlide. We will subsequently use a VisiGlide guide wire. And the first objective is to obtain cannulation entry into your dilated pancreatic duct. Fortunately, we don't have a lot of pancreatic parenchyma, which should allow us to advance the wire into the pancreatic duct. But this can be quite difficult sometimes, especially in the setting of if there's a lot of pancreatic calcification. So at the moment, I think that I'm in. What we now can do is to inject contrast, or we can advance the wire. So we will have to see, I will have to be very confident that I'm in, because as soon as you inject contrast, then you run the risk that, yeah, I think I'm in now. I think that's clear. Is that clear, Paolo? Can you see that the tip of the needle is inside the pancreatic duct?
Yeah,
it looks deep in.
It looks in.
This is one of the crucial steps of the procedure, because if you have a lot of calcifications, this can be really challenging. Yeah.
Do you perform any antibiotic prophylaxis or post-ERCP pancreatitis prophylaxis?
Absolutely, that's a very good question. So you can inject some contrast. Stop.
Please show the fluoroscopy.
I think that we're in, but I think that we're in. But there's some leakage back to the stomach as well, but I think we're in. So we can exchange this for the wire. So yes, we do give prophylactic diclofenac rectal suppository before the procedure, and we do give antibiotic prophylaxis based on the ESG guideline. We propose that it be administered at least once by administering the antibiotic 1 hour prior to the procedure.
We actually do that with every transluminal or transgastric procedure, so edge procedures, gastroenterostomy. We always use some pure procedural antibiotics. So we already confirmed that we're in the pancreatic duct. Now the next challenge is to get the guide wire to go to the right direction. I think this is the second step of 3 crucial steps. The first is to get into the pancreatic duct, which can be challenging due to the calcification. The second part is getting the guide wire through the papilla. And there we can use the cystotome to have more of a stable platform to get it across the papilla. You can see that we had to reposition a little bit, and that we're now into the pancreatic duct with the VisiGlide guide wire. So
do you always use the guide wire by yourself?
In this case, yes. I think this. I normally take it over in this case because of wanting to have the feel, and as you said before, the risk of so we could do the exchange. The risk of sharing, so at this stage I would normally do it myself. So now we would remove the needle, we would leave the guide wire in place. I think it is clear that we're not going to be able to pass the guide wire across the stricture into the small bell, so that will necessitate us creating a fistulous track with a 6-French cystotome.
And the other advantage is that we can use the cystotome as a diagnostic catheter to guide our guide wire along the stones through the papilla. So that's another trick you can use to get the guide wire to go through the papilla and perform your rendezvous.
So if you can have a look at this, Emma, if we can focus on the EUS image, one can see that you can now nicely see that the guide wire is in place in the pancreatic duct. So that gives us visual confirmation as well.
It's perfectly visible.
And now it is possible to advance the cystotome without any concerns that you may have a misplacement. So I think always rely on your visual cues, being the fluoroscopy image, being the echo-endo image. Combine these two images to make sure that you're always in the good position. So again,
so Scott, do you always attempt to pass the guide wire through the papilla only after passing with the cystotome? Or do you perform attempts before, in case you pass, not to perform the fistula with the cystotome?
What we have found, Paolo, is that if you have ductal drainage, the fact that you have created the fistula does not impact on potential adverse events. So in the guideline, we said that the rendezvous procedure is a procedure where you would advance the guide wire, but it's not always possible. I think maybe to prove that point, Tamara, can you just pull back slightly on the wire? Let's see if we can advance the wire, because if that is possible, that would be ideal. But I sort of think that it's not going to be possible. But let's see. If you advance the wire now further, Tamara, let's see if you can pass it into the small bell. But I think what we are seeing down there is an intraductal stone at the tip of the wire.
Yeah.
So it may be that it's not going to be possible to advance, and that
also,
we
on the US image were some really big lumen-filling stones there. So the chances of getting through are...
you can advance the guide wire further now, so that we have it more secured.
Let's not underestimate Schalk.
So I think that we're now in a good position, stable position, and now we will use the cystotome to advance. Again, the settings, we use the same settings as for ERCP.
There is a question from the audience. What's your choice of the guide wire based on?
I think that the most important factor for us is that to use a guide wire that is a monofilament guide wire that will not shear, because that is the concern when you use some needles, that they're shearing if you pull on the wire, which is absolutely true. But by using a monofilament wire, that doesn't happen, or happens infrequently. So I think that is also the VisiGlide is a wonderful wire because of the fact that it has got the same strength as the 0.035 wire, yet is 0.025. So that's an added advantage of using the VisiGlide.
We do prevent the use of the 0.18 wires because you cannot use a cystotome, or you have to exchange. So that's the reason why we tend to go for a 19 gauge needle and a 0.25 guide wire.
So you can see that Tamara is injecting very carefully some contrast. So we can, it's actually a very nice image. Maybe we can store that image. You can see that the wire is curled up. There's a stone in the distal duct. I think that with any luck, we should be able to pass the stone. Let's try, Tamara. I'm going to give Tamara some support with the cystotome. And let's see if Tamara can pass that into the small bell for a proper rendezvous.
The collaboration here between endoscopist and nurse is incredibly important. It helps so much if you have a nurse that gives you enough wire tension to advance the cystotome.
Okay. Can I have a sphincterotome? cannulotome. So I'm going to try, because with the cystotome I don't get close enough to the stone to be able to pass. So what I'm going to do is we're going to leave the wire behind. I'm going to come back with a cystotome. So in these types of procedures, you have to have a plan B. The plan B, if we do not succeed in passing the wire, is is to perform a pancreaticogastrostomy. But I think that in the second setting, we can even then perform antegrade ductal therapy. But obviously, the ideal is to perform retrograde therapy when you have access. And I think this is still, this should still be the aim of this procedure as well. But we're going to see if a cystotome won't help us to manipulate the direction of the wire more so that we can pass the wire across the papilla, be it the major or minor papilla. I'm not sure yet. What do you think, Michiel?
I'm not sure yet.
I think looking at the duct, at the course of the duct, I think it may be minor papilla.
So now we're exchanging for a sphincterotome, and using the bending action of the sphincterotome, you can sometimes it's easier to navigate the wire along the stones towards the papilla.
What about using an angle guide wire, an angle tip guide wire?
That is certainly the next option, but I think an angle tip will just simply curl up if we don't get closer. So in this position, we're going to ask Tamara just to put some tension. Pull back, Tamara, on your wire first, and yes, then you can tense up the cystotome. And now we'll see, can't we? Yeah, it's still difficult. I think there are stones there. But it's a very good suggestion to see if an angle tip will help. I don't think it's going to help, but let's first see. Tamara will try also to, I think that we not really helping us a lot. Okay, just pull back on the wire again. Pull back a little. You can now tense some more on the, let's see if we can, okay. Good. So let's release the tension of the sphincterotome. Let's try with an angle tip wire to see if that is helpful. Sometimes you can predict. Yeah, let's see there. That is better. But if you can wait for me there, just pull back the wire a little bit. Wait for me there. You can release your tension completely. Yeah, that's a lot better. Try now. Yeah. Okay. I'm just. Wait for me, I'm going to try to follow you. So this is the principle. We want to change the direction of the wire, but then we also need the catheter to follow, which it doesn't at the moment. And as soon as Tamara presses harder, yes. As soon as Tamara presses harder, it tends to push me out.
A little bit of torquing action sometimes also helps. This is not always the case, but sometimes a little bit of torque can help you drill your way through a stricture or through stones.
If you give a little more contrast, we can just see where the okay, stop. So there is, we know that there's passage, but the stone is really making a difficult. Try again. Okay.
I think what the participants can also see is that there's a little bit of a contrast extravasation near the scope. This does not matter if you have an adequate range afterwards. This will go away.
Do you have a minimum diameter of the main pancreatic duct to perform this type of procedure, or at least 5 millimeters or more? No.
I think that we sometimes will tackle ducts of 2 millimeters, depending on the indication. But I don't think that's the biggest concern about risk of failing is the size of the duct. I think if you quite used to this procedure. Smaller ducts can certainly be attempted.
The biggest risk factor in our retrospective analysis was not so much the pancreatic duct diameter, but more whether the pancreatic duct drainage was performed after surgery or not. So surgically altered anatomy was in our series more of a predictor of technical failure than the pancreatic duct itself.
Okay, let's do exchange. Leave the wire behind, and we're going to use the cystotome again, because that's not bad.
That looks good.
Gives me a bit. Now, if you pull back, that's there where the stone is, where we have trouble to. And as I thought, I don't think that the curved tip is necessarily going to be helpful, because the stone is really in our way. Let's see, if you push, let's see. Yes, I see if I can follow you a little bit back, pull back a little bit on the wire. I'll follow you. Okay, now advance again. Yeah, I think that maybe we will have more luck with the pull back a bit. Yeah, advance. And in that, if you can talk there, Tamara. So the objective would be to see if we can torque the wire to the opposite, in the opposite direction.
Schalk?
Yep.
Just a question. Do you usually fix a schedule, a time slot for this kind of procedures? I mean, do you try the maximum of your trial before quitting and performing the pancreatico-gastro procedure?
Yeah, it's a very good question, Paolo, because I think that one should know when to quit, and it's not easy for someone to, certainly like me, when you are set in wanting to make this work. But I think that normally after 30 minutes, it should be clear if this is going to be successful or not. I'm going to come back tomorrow, leave the wire back in, and we're going to do an exchange for the cystotome. But you're right, Paolo, I think that we have an option, and I think this is also the reason why I chose to enter into the pancreatic duct at the tail, because that gives us enough space to land a stent without any risk.
Yeah, you are absolutely right. But regarding in your experience, 30 minutes is a good compromise, not increasing the risk of complication due by the leakage or something.
What we know from our study is that the complication rate is about 30%. And it is mostly a mild pancreatitis that one can expect. So we already prepare the patient. The patient knows that that is the risk, and we see that in almost all our patients, certainly lipase elevation, and in about 30% clinically important pancreatitis, but we have never had a pancreatitis that was life-threatening or necrotizing, and that is very likely due to the fact that we have patients, very careful now, we have patients with chronic advanced disease. So.
And I do agree with the senior endoscopists here, but of course your biggest risk factor for complications is not performing adequate drainage. So if you have to take that extra time to perform a pancreatic gastrostomy, or you are able to perform a rendezvous eventually, that's the biggest preventer of complications, of course.
A question from the audience. If you think that what's causing this blockage are stones, why not use extracorporeal shockwave lithotripsy to kind of fragment the stones and try it again?
That's a good option. Yeah, we also we used to use this option. It is, however, an issue that ESWL is quite operator dependent, so you have to have someone that is really experienced in doing this. And what we now tend to do if we have a large obstructive stone which we cannot pass in the pancreatic head is just perform pancreatico-gastrostomy and then come back after 1 or 2 weeks and perform antegrade spyglass with a lithotripsy. And with this approach we have a high technical success actually. Whereas ESWL is sometimes hard to predict whether it will work or not.
So I think we, as Michiel said, we are not as enthusiastic about ESWL as we were some years ago because of the fact that we are, sorry, Tamara, just wait there. I'm just going to ask you to inject a little bit of contrast. Because of the fact that we now can clear the duct much better using spyglass. So first it is about ductal access, and second it is about clearance of the duct. And if we can't get retrograde access, next time we'll advance the wire and we'll obtain antegrade access with spyglass, and we will still be able to manage that stone. So if the stone is completely managed, then we would expect symptom improvement. And we know that with ESWL, we may only be able to target larger stones, and even then, we are not as enthusiastic as some years ago. Certainly, we don't have the same results as was obtained by the Devier paper. Inject a little bit of contrast. I just want to see where the duct ends. Okay, stop. So now we will place a pancreaticogastrostomy stent. We'll have this cooled down, and then in a week or two we'll bring the patient back for an antegrade spyglass examination to finish the job. So you have to have a plan B, and the plan B is placement of a stent to the stomach.
What do you think of a 7 French 9 centimeters or 7 centimeters, Schalk?
Yeah, I think that's a good idea.
9?
I think that's a good idea. I would be a little bit concerned about 9. Will be probably too long. Okay. So 7.
7.
Yeah.
7. And the goal at this second procedure, which we will schedule, is also to eventually perform rendezvous. So at the second procedure, we will do a spyglass, straight or a single pigtail, Schalk, you can choose.
Straight is fine.
So the goal at the second procedure.
Sorry, the single pigtail.
In the next
at the
procedure,
second procedure will be to clear the ducts, but also to perform the rendezvous. So we will still be. Our goal is still to perform rendezvous then in the second procedure.
In the second procedure, you will use a spyglass and that it's 10 French. So any indication to leave in this occasion a 10 French stent in order to have the same fistula tract of spyglass, or you don't have concern about it?
If your pancreatic duct is big enough, you can do that, but you can also dilate it in the second procedure, and we tend to do that because if you go too big too fast in pancreatic duct drainage, these patients will have sometimes pain. So start low and go slow.
Okay.
So yes, a 4 millimeter dilation balloon.
So before placing the stent, we will prepare the tract, the transgastric tract a little bit, then we will perform 4 millimeter balloon dilation, and then we'll place the single pigtail stent, which is 7 French, 7 centimeters. But again, there's nothing wrong with placing a bigger stent, but you'll have to tailor a little bit to the pancreatic duct diameter, and we tend to use slightly smaller diameter stents in the beginning.
I think there's also a risk that if you try to place a 10 French plastic stent in this case, that you will not be able to advance the stent across the gastric parenchyma, gastric wall, pancreatic parenchyma into the duct, that you may lose your position, which should not be the case if we're going to use a smaller. So I think that, as Michiel said, we would rather play safe. The patient can come back within a week or two. The fistula forms very quickly and matures very quickly. You can inflate tomorrow. Forms very quickly, and so you can bring your patient back within a week. So it's not a prolonged issue. If the patient does well, he does not present with pancreatitis in the next day or so, then you can bring him back quite soon.
I think in the beginning we were concerned that these fistulas took a longer time to create, just as with the gallbladder drainage or edge procedures. But what we now see is that after 1 or 2 weeks, it has already matured enough to perform a second procedure. what you also see in a lot of papers is that endoscopists use 22 gauge needles and 0.18 guide wires. In our experience, of course, this could be selection bias, but in our experience, technical success was a bit lower in this group with the smaller diameter tools. So we always try to use a 19 gauge needle. So we now perform the balloon dilation, now switching and exchanging to the single pigtail. What you also can see, and this is already something that Schalk doesn't actively think about anymore, is that he constantly controls the EOS scope position, and that we constantly keep the EOS scope positioned visualizing the wire. So if we place the stent, you will have a really nice direct trajectory and you don't risk dislocating the stent. So always before performing any stent placement, check your position so that you're in nice alignment with your target structure.
With the scope that you're using has an elevator that has a blockage system of the guide wire, because
Correct.
not always have. So.
But you have to be careful that it doesn't work as well as with the classic ESCP scopes, so don't rely on it too much. So there the stent goes.
Stop. Now this is the most tricky part, and we'll have to be very careful that we have pre-prepared. There it goes. Okay.
So you saw Schalk realign the scope again so that we have a nice direct trajectory, as we said, and there the stent went in. Now we switch to the endoscopic image as well.
For the audience, if you have any questions, please don't hesitate to send them over.
Can we have the endoscopic view? Thank you.
We now retract the guide wire in a couple of moments and then push out the single pigtail stent. Now at the 12 o'clock position, the guide wire is visible and the stent.
Okay, alles uit.
And there it goes.
Very nice.
So I think
Michiel? Yeah. Sorry to interrupt you. It was a very, very nice presentation and very, very nice examination. Sorry to leave because we need to move to our last case, but we will see you tomorrow. Thank you very much.
Thank you.
Thank you, Paulo. Bye-bye. Fantastic presentation. Thank you.
So the last case of today is a 49-year-old male without a relevant family history and type 2 diabetes. Since November 2022, he had involuntary weight loss with abdominal pain and poor glycemic control. He performed body CT scan, which showed 5 centimeters inhomogeneous solid deletion of the pancreatic head uncinate process that infiltrates the mesenteric vessels and the portal confluence. At the body exams, normal values of CA 19.9 and cholestatic levels. Today's procedures is US plus fine needle aspiration. Operators are Professor Sahai and Petroni.
Anand?
Hello, can you hear us?
Anand, welcome.
Hello, everybody. Thank you very much.
Just landed.
Yeah, just.
And because you are just landed and so you are tired, I give you 3 minutes to do everything.
Yeah.
I think that you are the one and only that can perform in 3 minutes.
Yeah.
So
okay,
thank you very much.
So when somebody is referred for a pancreatic mass, I prefer not to look at the films. I just want to get an idea myself. And I tell the fellows the first thing I want to do, I always start here at the liver, and then okay, start at the liver, look for the portal vein, and I'm just going to torque. And look where my hand is, it's up near my head. It maximizes the movement to the scope. And the first thing I want to see is the PD obstructed. And you see the pancreatic duct is not obstructed. So right away, I'm asking myself questions. This is a little strange for somebody with a 5-centimeter pancreatic mass in the head to not have a pancreatic duct obstruction. And you can see he doesn't have biliary obstruction either. He doesn't have any jaundice. So that's the first thing here. So we go out here, take it all the way out to the tail. You can tip up, go left. You can see the aorta. You can see the celiac axis here. This all looks good. We can see SMA here. Very nice view of SMA. Slowly just trying to keep it in view. And it's kind of heading over here. You get a feeling this is where the lesion is over here. I'm going to push in a little bit and just tip up and pull back and get a little bit more, just a better, closer to the confluence. So you can see from the stomach here, you can see the confluence. You can see SMV here. And then splenic vein should be going off into the tail back here. So from this view, you can see this lesion here. And you can see the vessel looks pretty good from here, actually. There's no signs of obvious vascular involvement. The vessel changes shape a little bit, which is always a little bit worrisome, but it's not obvious vascular involvement. That being said, I think it's important to look at the vessels from as many stations as possible. They can look good from one station and very bad from another one. So we see this lesion here. It's kind of heterogeneous, a little bit microcystic, so we'll get a better view from the bulb. So just to show you from the stomach, we already have a good idea what's going on with this lesion. We're going to go into the bulb now. Okay, I'm in the bulb. You want to give it a little bit of right and get a little right on the apex. People don't go deep enough into the apex. Then you go left. Okay, so right here, actually from this position, I can see the ampulla is right here, and here's the bile duct, and this is the pancreatic duct. So once you're here, you torque left, and you want to find the portal vein in the hilum and the bile duct next to it, and then you can follow the bile duct down to the papilla. Okay, and you can see the lesion is over here. In this position in the bulb, when you see a lesion over here on the right side, to me, that's the uncinate process. Okay, and you can see now this lesion does have a microcystic component. If you want to put on the harmonics or the whatever you guys do, so you can see there's a microcystic component here. And where's the pointer go?
Pointer is here.
Yeah, okay. So you can see it's a mixed microcystic, slightly solid in places. But to me, this is pretty typical for a microcystic adenoma. And from this position here, I get the portal vein again here. And here also, the vein looks pretty good. It changes direction a bit, but it goes away. So overall, I think there's a hyperechoic plane with the vessel. So no signs of vascular involvement and no signs of bile duct obstruction. Okay, but there's a bit of a solid component in here, which could be a little concerning, but at the same time, if his PD is not obstructed, that kind of goes against it being malignant. Then I'm going to go into D2. This is the hardest station. So I tell people, go into D2, keep the scope up against your chest like this to the right. You can see the air. This is the duodenum here. So this is all the uncinate process right here. So you pull back till you get some resistance, and you're seeing pancreas. And to find the papilla, I say stay here and just torque left 25%. And if you don't see anything, go back. Pull back a little more, torque left 25%. You don't see anything, come back a little more, left, and you're looking just for something dark coming out of the papilla, and it's going to be over here. It was over here. And pulling back a little more, and then you see there's some duct here. So once you see this, you know the papilla is going to be here, so you can pull back through the papilla, and then there's the ducts coming out of the papilla. This is the pancreatic duct, and here's the bile duct. And here's the lesion over here. So it's another view of the lesion here. You see it does appear to be compressing like SMV a little bit, I think down here, but there's still a hyperechoic plane with it. So overall, it still looks fairly benign, but I think we're going to biopsy anyway, just to make sure in that solid part that there's nothing dangerous going on.
Could contrast enhancement could help in the definition of this lesion?
It won't help me, but it'll maybe help somebody else.
I will perform because there is a different type of lesion. We have a microcystic lesion in the peripheral part and something that appears more solid. So in my opinion, could be interesting to see how is the behavior contrast in the solid component.
Okay.
Okay, thank you. So
Remember, we have 3 minutes, right?
I know.
Okay. So I just stay on this like this, yeah?
Yes,
Okay.
and a little bit like this. Okay, you're ready to start. Almost ready. Yes, we are injecting the contrast just now.
I'm very excited.
I can imagine. I know. So, psychiatric. Okay. So also the solid component has a
Vessels.
serious.
Yeah.
So now I'm.
You're more reassured.
Yes.
Okay, good. I'm happy for you. Okay. Apparently, they're going to be coming out with the Doppler that'll sort of be as sensitive as the contrast.
Yes.
Soon, I heard. Anyway, that'll be nice.
Wait.
Okay, so we're going to biopsy.
Yeah.
Okay, so I'm going to take a 22 gauge acquire.
Okay.
I'm going to try and focus on the, where are the point? I'm trying to focus on the most solid parts. I'm going to try and not go into the gastroduodenal artery. That would be bad. And I'm going to use no stylet, no suction, just go straight in here.
Which scope are you using? Yes.
This is the the Pentax something. Okay, Pentax, what's all right? EG38 J10.
What you usually use every day, I think.
I use the old ones.
Okay.
We're from Canada, now my phone is ringing. Okay, so I'll give you this.
If you're in doubt that it's a cirrhosis adenoma, do you perform antibiotic prophylaxis?
Yeah, honestly, cystic lesion, it's not a bad idea, but we don't do it before anymore. We just do it after. Because we used to give a lot of antibiotics to people in case we were going to biopsy, and then we ended up not biopsying. So, so far, we just do it after, and we haven't really had any major issues. I think the important thing is to only go in once, and if you want to go in twice to really change needles. So I'm in position, I lock my up down, I'm going to put the needle out till I can see it, there it is, up here, okay? And then now I'm going to focus on the elevator. Is he okay? Oh, thank you very much. Okay, so I'm going to push, whoops. Okay, push this in here, losing it a bit. And just like this, okay.
Perfect.
Like this, I'm losing the needle. I'm going to put the gain down, something that helps see the needle a little better. I'm going to go in, and then now I'm going to look for the needle. It's going a little bit, okay, it's way down here. Okay, so the important thing here is to go all the way through. Oh, this is coming off a lot. And come back, go back in. You might come out, move over with the elevator and go somewhere else. I think it's important to actually come out of the lesion, but not go back into the GI lumen, which is contaminated. Going one more time here, maybe one more place. Really coming out of the lesion and going somewhere else with the elevator. It's hard to see here, but that's what I'm doing. Okay, and that's about it. And then we'll give this. So we usually just push it out with air into the formalin. Okay. You guys can do what you want. I think in this type of lesion, particularly, using suction would give you a lot of blood. And as I say, the advantage of no suction is that you get very little blood, so you can see if you have a good core or not. So we'll see what that looks like.
Anand, Maria Chiara?
Yes.
Yeah, sorry to interrupt you. It took to you 5 minutes, so you are in a good shape, Anand.
Oh, yeah?
Beside the flight. So thank you very much for this demonstration. And now we can move to the auditorium for the next session of lectures. And we close from here from Milan. But stay tuned because at 4:13 we go back to USA.
It's all the equipment, I guess, huh? So was the sample look like anything?
So
Like,
thank you.
was there tissue?
Thank you for these interesting cases. Now we get started for the next section, in which there are 2 lectures. The first is from Professor Scharker van der Merwe from Leuven. I don't know if he is connected. He has the time to connect it. Yeah, they told me just 1 minute. Otherwise, we can shift to lecture. I don't know if you have some. Okay, can we move to the second lecture? Okay, so a little change to the program. I call on the floor Amrita Sethi, which are gonna talk about Adam versus Eve. So, what women want. This is probably for men one of the hardest questions of their life.
I want to thank the directors very much for inviting me to this wonderful conference, as well as giving the platform for this talk, which may seem unusual for a course on EUS, but I think the intention was really try to recruit women and diversity into our endoscopic field. So these are my disclosures, and I also do have a disclaimer that this was not my title. I didn't come up with this. First of all, I'm not a creative myth student, and also when we ask the question what women want in general, this is actually quite simple and makes for a very short talk. We want to run the world. That's it. That's the end of the talk. No. Actually, what do we want in endoscopy? So normally, to answer this question, I show this video, which really is basically a compilation of all of the amazing procedures that we do in interventional endoscopy. But because of time constraints, I'm really going to summarize what the video inspires. And what women want, I think, in endoscopy is really to be able to practice this amazing field. All of these procedures that we do they're amazing, they are inspiring, and we have passion for doing these procedures, and we want to be able to practice what we have passion for. We also want recognition for our expertise in the field and contributions, and have an ability to inspire the next generation. And ultimately, we all, men and women, want to improve our outcomes for our patients. It's important that we think about what we don't want. We are not asking for opportunities just because we're women. We don't want to be placed on the edge of the glass cliff, which is basically where we're only given responsibilities in moments of crisis with no resources to help us so that we are set up for failure. We don't want to be superhuman. We don't want to be doing 10 things at one time and say that we can do that. We just want to be able to practice normally like everyone. And don't want to have to choose between family and work. We want to be able to create some type of balance, to do everything with the same degree of expertise. And most importantly, we are not creating a space where we are trying to lay blame or correct the wrongs of the past, but we just want to move forward in a constructive way. So let's just start with what is the status of women in endoscopy. Based on the US numbers, we can see that actually if you look at women who are in medical school, they're almost 50%. At this point, they are greater than 50%. However, these numbers drop down significantly as we enter specialized fields, so that by the time women enter GI and reach senior careers, it's less than 25%. And advanced endoscopy fellows specifically years ago had been less than 19%. Globally, women actually make up less than 20% of endoscopists. And this is some data that I just recently learned from my colleague, Dr. Sharmila Sachi in Malaysia, that if you look, again, throughout the world, the only thing that's missing here is South America, If we look at who's entering medical school, greater than 50% across the board, even as high as 80 to 85% in areas like Pakistan. But when we look at GI trainees, these numbers fall to abysmal levels, with, for example, less than 1% in India, or just one physician in Egypt who practices third space endoscopy. The only sort of exceptions to this are in Philippines and Thailand, where you have almost 50% of women in GI. And one could say this is because of the numbers of women leaders in the field, which make up at least 30%. So there's some correlation between having diversity in leadership and having diversity in your workforce. So what are the problems that we are trying to correct by recruiting more women into the field? I'll show you that we want to maintain the future of endoscopy to start with. We need to recruit. We need to find out how to retain these women and medical students. And we want to make sure that we're all having continued relevance in the field. And then again, we always return to the patient's needs. So to describe why I think it's important to think about recruitment and retention, let's look at how the field has evolved. 2008, when I finished my fellowship, these were the main areas of interventional endoscopy: ERCP, EUS, EMR, and luminal stenting. But if we move to the current state, look at all of these fields. The field has exploded. Therapeutic EUS, as we've been watching today, anti-reflux procedures, metabolic and bariatric endoscopy, third space endoscopy, ESD, and resection. And if we go into the future, we're talking about how AI is playing a role and really growing these other spaces. This means that we have to recruit more GIs to enter the field in order to sustain all of these amazing procedures and areas that we've done. How are we going to do this? Are we going to get more people to enter medicine? Absolutely not. In today's age, people realize they can make more money and be happier without going into medicine. So in order to keep the current state going with all these new procedures, we have to look about how we're going to recruit. We have to keep in mind people are resigning. COVID really decreased the workforce across the board. And across the board, we also have to look at our own field. Look at who are going to be the next leaders. These individuals have been our pioneers. They have led us in this field. But who's going to be the next generation of leaders to take us into the future? Everyone wants to know this. Industry wants to know this. Our own students want to know this. So why is it important when we think about recruitment and retention to think about having women as part of that population? Well, we've done a number of surveys now that show that patients actually prefer same-gender providers, especially in the Middle East, and that in fact, if they don't have the same gender, they delay their care. That's really tragic. Additionally, surgical studies show that patient-provider discordance is associated with worse outcomes. And lastly is the provider satisfaction. We do a better job when we're happier at what we're doing, and there's really no differences when you look at surveys of women and men wanting to enter this field. So I would argue that the future of endoscopy is women, not exclusively women, but inclusively, including men. I was going to make this the only reference to Adam and Eve, but then I realized it's actually the reverse. Again, I'm not a student of creative myth, but anyway, I do think that when we look at the future, we're looking at women and what they represent in terms of our characteristics as potential leaders in the field. So what are the barriers to women in the past in terms of recruitment and retention? Well, studies, again, the data shows it's because of lack of leaders and visible mentors, experience with gender bias in the workplace, imposter syndrome, which is a huge, huge problem, I think for everyone, but mostly for women, concerns for family planning, pregnancy, and fertility issues, again, feeling the need to make choices about whether you continue with your career or your family, and lack of a safe and comfortable environment, whether it's with regards to equipment we use, like ergonomics, or to scheduling to allow for our daily lives to be balanced. So how do we think about the solutions? Well, anytime we think about change, we have to think about sort of the rate of change. Change will happen naturally, and if we just follow along, it's sort of this slow curve. And in a recent article, which is excellent, by Amy Oxentenko, the future next year's president of ACG, she labels this rate as the critical mass. You have to reach the critical mass in order to make change. But one argues that's not enough. We actually have to have disruptors, or catalysts to make this change happen now. And these are some of the strategies that I would say can allow us to try to do that. You have to dare to be uncomfortable every day for just a moment. Think about somebody else's perspective and make yourself uncomfortable in the decisions that or when you're thinking about decisions. Diversify leadership, do the research and provide the data so that we can actually guide how to make changes. Change the environment, practice sponsorship and mentorship, allyship, increase the visibility of role models, embrace innovation, and elevate and amplify perspectives and voices of diversity. And I'm going to give you some more details. So why is it so important to diversify the leadership? Well, if we think about what leaders are, or who leaders are, they're the ones who are setting the goals. They're choosing core missions, and they are making decisions and strategies in order to actually create those missions and go forward. And once you have leaders who have diversity and can think in diverse ways, they can start to practice sponsorship and mentorship. And these are two terms that are really important to think about as leaders. Sponsors actually invest your capital, whether it's financial, professional, or political, in other individuals in order to help promote these core values. Mentors help guide the way and inform your decision-making based on your own core values. For both of these, it's really important as trainees and people coming up in the field to remember these people are not doing the work for you. You still have to do that. They're not obligations, they are privileges. And this type of mentorship and sponsorship can come through all of our societies, which now all have committees and groups to help individuals become recruited into the field. And if it doesn't exist, we can also create new platforms like Women in Endoscopy or WIGNAP, which is the Asian version of this, founded by Dr. Sachi, as I mentioned, who has really been a pioneer for us in the field of promoting women. Once we form these platforms, we have to collaborate. We are not fighting each other. We all have collective missions and goals, and we have to work together as individual societies and with our larger societies to use their platforms in order to spread these messages and help promote women and recruit into the field. And again, we have to look for the data, do the research, and come up with the answers that will help us guide other individuals in the strategies that we can use going forward. And there is now a plethora of research and manuscripts available that can help provide these guidelines. And really, in these guidelines, specifically give strategies to address change, whether it's in the endoscopy suite, in academics, in research, or even in achieving work-life balance. And as I said, once we put in place leaders who can think with diversity, they can start to change the environment instead of just trying to change the individuals. You can do this by setting forth your missions and your values, changing the dialogue and the definitions of success so they're more inclusive, and enhancing the skill set, including providing leadership training so others can become leaders and providing coaching. It's important that everyone gets bias training, men, women, everyone, because if you're not aware of these biases, you won't be able to change. You must provide an atmosphere of safety, both physically as well as mentally. On local levels, like endoscopy units or in your divisions, you can do this by increasing the presence of women and diversity at the table, whether it's making them chief of endoscopy or having more meetings with all of the unit players and amplifying their voices with their ideas, nominating people for positions, scholarships, awards, and also recognizing good work and elevating that work to someone where it matters. So if someone's up for promotion, let the supervisor know what a good job that person did or how they deserve that promotion. You must address policies that are causing the barriers. For example, pregnancy, work hours, meeting times. This needs to be done at a local level by the chiefs. And finally is to embrace failure and complications and turn them into learning opportunities, not to discourage individuals from moving forward despite failure. On national and international levels, we have to increase the visibility of role models. There's a common saying that if you see it, you can do it. People look to see themselves in those who they're watching, whether it's on camera or on stage. And we can do this through our courses, we can do it through social media, or we can develop special fellowship and observership opportunities so that we can teach them. There has traditionally been a lack of visible role models. If we look traditionally at some of these courses, the faculty have been all male. And what's important to know about this is that it's not that we're saying, again, that these are not our friends. All of these individuals on an individual basis are our mentors. They are our friends. They are our allies. But if you don't make a conscious effort to think about how this comes across, you will miss the fact that it does not actually, isn't inclusive in who it will inspire. So this is EU Ascendo last year. There's one woman, Janine Van Hooft is there. And if you compare that to courses where all the women, all the faculty are women, you can imagine that in terms of inspiring people to enter the field and feel like it's possible, see themselves in there, this will probably recruit more people than the prior image. And in that, we have to ask for allyship. Allyship is when, in this case, men help promote, use their platforms, and help take on our mission and value and support us. And for example, in Endoscopy on Air, Ali Rapici took on the mission and made sure that his faculty for Endoscopy on Air was at least 60% women. And I was very happy that last year when I showed these pictures to Paolo, that he didn't throw something at me or get really upset, but instead took on the challenge, as did some of these other new allies, and became our allies and said instead, we will make it a mission to try to recruit more women and increase the visibility. And all of these individuals for this year's courses going forward have made it part of their curriculum or agenda to address this issue. We also have to ask our industry partners to be allies, whether it's who they bring to the table for consulting, for ideas of the future, and thinking about the diversity they need to employ, but ways they educate, and also in having gender equity in their patient care goals. And then we need to really elevate voices and promote other people to make sure that we're getting perspectives out there that are diverse and that people can identify with and have questions and perceptions answered so that they can move forward. And I would say also another thing is embracing innovation. For example, AI. Traditionally, AI is associated with increased adenoma detection rates. But, and this is a artwork created by AI, if we think about it, AI really exists in many formats, and one of the most, I think, useful ways it will play a role is actually empowering us to become more human. For example, taking over tasks in the electronic health record, or dealing with patient-focused issues, and returning our time to us as physicians so that we can have more work-life balance. I think this will help with women staying in the field, not having to make choices. Other areas of innovation are devices that we're using to deal with things like complications, like bleeding and perforations, so that we can actually have more confidence in pushing our boundaries in the procedures that we're doing and getting more involved in aspects of this field. And ergonomics is probably one of the biggest growing areas for innovation. We all need to treat our bodies better, whether we're men or women. And the changes that we can have with ergonomics and the attention that we can pay to the area will allow people to stay in the field and not be deterred by things like a safe, unsafe environment. And the other thing that we need to think about is if women do have to leave the field to take care of their families, what about finding ways to bring them back? And this was a concept introduced by Dr. Sachi in the course I was just with her. Think about ways that industry can help us for them to re-enter the workforce, get retrained if they need to, so that they can realize the field. And actually have women teach women how to expand their practices, like this course that's actually happening as we speak. So the question is, can these strategies work that I've outlined for you? I'm going to give you a real case example, a real world example that just happened, so stay right off of the presses. This is an example where we had a sponsor and an ally in Dr. Nagi Reddy, who recognized, as I mentioned, that less than 1% of women are GIs in India. Only 5 women practice advanced endoscopy in the entire country. So he recognized that something needed to be done, and that the way to do this is to increase the visible mentors that these individuals could see. He invited women expert endoscopists from around the world and held a conference that was exclusively featured women who gave expert talks in all areas of advanced endoscopy based on their expertise and oftentimes their own data. These were outstanding talks that were informative and gave algorithms to how to manage patients. And they also were the only faculty performing procedures. And these procedures were performed with so much skill and excellence, even in cases of failure, that he actually commented that he felt like this was some of the best endoscopy that he has seen, regardless of gender.
Amrita, we have to move to the end.
The last thing I just want to say is that, in fact, history was made. For the first time, Indian women endoscopists perform live endoscopy, and they are going to be there to stay. And we ultimately created networks and have definitely inspired women within India, and I would say globally, to advance in the field. So similarly, we're making success with more fellows entering the field, and I truly believe if we practice some of these strategies, the future of endoscopy is bright. Thank you very much.
Thank you. Thank you so much. We are a little bit late. These are lectures, so there are no questions. I guess that Professor van der Merwe is now connected. Can you hear us? Hello?
Can you hear me now?
Yeah, now perfect.
Okay, perfect.
So thank you. The floor is yours.
Thank you. I just wanted to thank Paolo for the invitation to speak. So my brief was to talk on the use of EUS in liver disease, but I have chosen also to focus specifically on EUS guided portal pressure measurement. These are my disclosures. From the perspective of EUS, I think we have mainly used EUS in the past as a diagnostic tool when we needed to access a liver lesion that was otherwise not accessible. Recent developments in the field of therapeutic EUS has certainly changed the field. We now can manage complex biliary problems when ERCP fails especially, but there seems to be a lag in terms of EUS-guided vascular diagnostics and therapy, and although that is taking off, I think there's still some work to do in the field. So in my talk, I will focus, as I said, on EUS-guided portal pressure measurement. So why would EUS-guided portal pressure measurement be of interest to the hepatologists and to the endoscopic community? Well, I think it stems from the fact that in a patient with liver disease that is progressive, we know that as a patient progresses through stages of fibrosis, more advanced fibrosis, and ultimately cirrhosis, there will be an increase in the resistance of portal flow that may result in the development of portal hypertension. And what we know is that there is a correlation between the development of clinically significant portal hypertension and the progression from a compensated state to a decompensated state. This stems from studies in the past that in this study specifically, the authors looked at patients with hepatitis C that were about to start antiviral therapy. They all received at baseline a HVPG measurement. And what the study showed was the probability of developing ascites, hepatic encephalopathy, and variceal bleeding was increased when the HVPG rose to more than 10 millimeters of mercury. So we now know that HVPG is a strong predictor, HVPG or portal pressure is a strong predictor of future decompensation in the compensated cirrhotic patient, even in the absence of cirrhosis. What we also know, which I think is very important, is that when a patient develops portal hypertension, there's formation of varices, sodium retention. Once the portal pressure exceeds 12 millimeters of mercury, we know that the complications will increase, such as development of ascites and spontaneous bacterial peritonitis and rupture of vessels. But what is also very important to understand, and I think this is one of the main objectives of this talk, is to convince you that if we identify important portal hypertension along the way, even before these complications were to develop, by a proper management, the risk of these patients can be decreased by the introduction of beta blocker therapy. So there is a good reason to identify portal hypertension early on because it has implications. So what are the implications? And the key principles that I want to convey in the talk today is that portal pressure predicts the onset of liver-associated complications and death in patients with cirrhosis. To be able to measure portal pressure has prognostic importance. It will guide us to make clinical decisions if we can measure portal pressure, especially if this can be done with the least invasive technique in a serial way. But we also need to recognize that HVPG as a measurement is an imperfect gold standard. So what is HVPG? How does that work, especially in people not used to this? HVPG is an indirect portal pressure measurement through the catheterization of the hepatic vein. So under normal circumstances, when this procedure is performed, the interventional radiologist will advance a catheter into the hepatic vein and determine the free hepatic pressure. The interventional radiologist will then inflate the balloon to determine the wedge pressure, and the difference is what we refer to as the HVPG. So what does that mean? Well, we accept that the HVPG, or the wedge hepatic pressure, means that there's increased resistance of flow based on pronounced fibrosis or contractility of stellate cells that is transmitted equally across the lobule of the liver. So when a balloon is inflated, the wedge hepatic pressure determined that it is reflective of the pressure across the lobule. The interventional radiologist will have the ability to confirm his measurements by using a chart where the measurements are displayed, so that he can confirm when the balloon is not inflated compared to when the balloon is inflated, which gives some extra assurance regarding the quality of his measurement. So when does the correlation of wedge hepatic pressure and portal pressure, how accurate that is when we compare the two measurements? So what we know is if the interventional radiologist is to measure the wedge hepatic pressure, and afterwards, should he then or she then advance a catheter into the portal vein, that there is and measure the portal vein pressure directly, then we know that there's a good correlation between the portal vein pressure directly measured compared to the wedge hepatic vein pressure for hepatitis C cirrhosis, alcohol cirrhosis, and the combination of the two, where one can say that there seems to be an excellent correlation achieved. However, when we look at NASH cirrhosis, we see that the correlation between the direct measurement and the wedge pressure falls significantly, and there's only a moderate to even poor correlation between NASH cirrhosis between direct portal pressure measurement and the wedge hepatic pressure measurement. And this seems to be clinically incredibly relevant. In a recent study, it was shown that the wedge hepatic pressure, when compared to the portal pressure in NASH, that there was a difference in terms of discrepancy between these two measurements, sometimes of more than 5 millimeters of mercury, occurring in nearly 40% of patients. We also know that HVPG is notoriously ineffective when we measure portal pressure in diseases that affect the portal tract because of sinusoidal buffering, where there's no correlation between wedge hepatic pressure and true portal hypertension. So these limitations, and certainly, especially in the setting of NASH, we can conclude that for most, the most common liver disease, NASH, that there's a very poor correlation between wedge hepatic pressure and HVPG, and that it will be false in nearly 40% of cases. So why in NASH is portal pressure so important? Well, we know that in NASH that portal pressure increases earlier in NASH. We also know that portal hypertension may develop due to the accumulation of fat droplets in the hepatocyte and subsequently impinging on the flow of blood across the sinusoid. Even in the absence of important fibrosis or cirrhosis, portal hypertension may be a direct issue, a problem in NASH. And we also now know, based on animal models especially, that in NASH, that as the portal pressure increases in NASH, that it may further stimulate fibrogenesis. So that the development of portal pressure, an increase in portal pressure, is already of clinical significance in NASH. So in the absence of HVP, in the absence of cirrhosis, we now know that the hepatic venous pressure gradient in NASH is even further, there's even a further discrepancy compared to the direct portal pressure measurement. So increase in portal pressure may be especially important to measure in NASH, especially in the non-cirrhotic population, as this already signals the development of progressive disease. And if this can be achieved through a non-invasive or less invasive method, we may be able to intervene before the development of fibrosis. So how can portal pressure measurement help us? I've already convinced you that it can help us to determine the diagnosis and in terms of the diagnosis of type, as well as the degree of portal hypertension, that there is prognostic importance if this can be measured, but can it also guide us in clinical decision-making? And I think this is where the recent Baveno guidelines should be included when we speak about the potential application of measuring portal pressure. What Baveno 7 says, now this is a group of excellent physicians dedicating themselves to the management of portal hypertension, yet this group, despite the availability of HVPG, will still advise the use of surrogate markers such as elastography in order to select patients where there is a higher likelihood of having clinically significant portal hypertension, so as to assume the development of portal hypertension underlying. And I think that this is what is very difficult to understand. Even in the age of wanting to measure and needing to measure, we still rely on surrogate markers to infer the presence of clinically significant portal hypertension. Why is that important? Well, I think it is important because our take on the management of chronic liver disease has completely changed. In the past, we would wait until a patient develops varices in order to start beta blocker therapy. But now, based on the advice of Baveno 7 and clear studies that indicated that if beta blocker therapy can be started in patients with clinically significant portal hypertension, even in the absence of cirrhosis, it may prevent these patients from progressing to decompensation events such as ascites, encephalopathy, and variceal bleeding. So there is now a true need to be able to measure portal pressure more accurately and also less invasively in our patient population. So what is the principle of EUS-guided portal pressure measurement? EUS-guided portal pressure measurement, we insert the EUS standard EUS scope, linear scope. We would advance a needle that has been specifically developed into branches of the hepatic vein. and we would do the same for the portal vein to measure the pressure in each of these systems. What I think is very important to understand, and we will demonstrate that tomorrow in the case that we will show, is that it is all about standardization. We as a fraternity need to really standardize the way that these measurements are performed, because otherwise we will lose the interest of the hepatology community if our measurements are not as accurate as HVPEG is supposed to be. So we will show you tomorrow how to standardize the level of the phlebotic access using a laser before the needle is calibrated, the transducer is calibrated, and the procedure can be performed. Once that is done, the needle is advanced into the portal vein, branch of the portal vein or hepatic vein. We would record the pressure. We would flush, and by recording the pressure 3 times, the average will be taken, and the portal pressure gradient will be determined by subtracting the portal pressure from the hepatic vein pressure. Now, this is what it looks like. We are performing the encounter study where we are at this point comparing HVPG measurements with EUS-guided measurements in the same patient at the same time, because there's an absolute need now to understand what the correlation is between these two measurements. But if you do that not in the same patient at the same time, it is very difficult to extract any meaningful results. So the encounter study is a study that is performed in Leuven, in Rotterdam, in Barcelona, where HVPG measurements will be done simultaneously. Here one can see the needle into the hepatic vein, and here one can see the endoscope with the needle entering into the portal vein. So, Mr. Chair, is this technology ready for prime time? I would say no, it's not ready for prime time, because we still need to understand some issues. We still need to understand the correlation between HVPG and EUS-guided portal pressure measurements, as I've discussed, specifically because the principles of the measurement are different. In HVPG, it's an indirect method. With EUS-guided measurements, it's a direct measurement. So the principles are different. We also need to understand that HVPG is an imperfect gold standard. So we are comparing ourselves to an imperfect gold standard and trying to draw conclusions from that. What defines normal or non-clinically significant or clinically significant portal hypertension for endoscopic ultrasound still needs to be defined. We cannot just extrapolate the values that we have been presented with through research in HVPG. And then there's an issue with quality control measures. The intervention radiologist can measure the pressure and have that displayed for quality assurance purposes. We at the moment cannot do that, but we have the visual confirmation that the needle is in the vessel as an assurance of the position, which the intervention radiologist cannot always confirm. We still need to define what chronic liver disease populations will benefit the most from EUS PPG, and especially now with the NASH issue that I've shown you, where HVPG is notoriously unsuccessful in obtaining useful measurements. I think that there is a potential niche where EUS PPG can focus on. We also need to define what does this look like in the future. The endoscopy suite, will it be a suite where interventional procedures can be performed and only interventional procedures, or are we going to use any suite for that purpose? We need to understand the type of sedation and the ideal position of the patient. We need to better know the position of the transducer. As I've shown you, we've got some good ideas regarding how this can be standardized. And then lastly, who should do these procedures? Should it be people that are specifically trained in both liver disease and endoscopy, because you still need to be able to interpret what these values mean. So lastly, can this technology guide us in clinical decision making? And my colleague Wim Laleman and myself came up with this slide a few years ago, where we think that this is probably where the field of EUS-guided portal pressure measurement is likely heading. And that is that we would likely still need one or other tool to stratify a patient, and we propose that time tissue elastography values of more than 15 kilopascals to then stratify a patient for EUS portal pressure measurement. And there are three potential outcomes. The patient may have no portal hypertension with a low risk of decompensation, HCC or liver-related death that can simply be followed 2 years later, for instance. The patient may have non-clinically significant portal hypertension where the pressure is low, comparable to what we would now expect to find with HVPG measurements of between 5 to 10 millimeters of mercury. And this would be a very interesting group because with the development of new antifibrotic drugs, drugs that can prevent portal hepatic decompensation, to study the gut-liver axis, those are potential ways where this technology may help define this group in whom these drugs can be tested. And then the last group, the patient with clinically significant portal hypertension, where the procedure can be combined with gastroscopy, but more importantly, where this technology can be used to identify patients that do not respond to beta blocker therapy so that alternative measures can be taken either in non-responders early diversion to TIPS or endoscopic band ligation or to optimize beta blocker therapy in the patients that do respond until you see a decrease below 10 to 12 millimeters of mercury. So to conclude, I think that portal pressure predicts the onset of liver-associated complications and risk in patients of cirrhosis. To us, we think that EUS-guided portal pressure measurement shows enormous promise to supplement HVPG, not necessarily to replace HVPG. EUS portal pressure gradient may be especially useful in the setting of NASH, where HVPG, as I've already mentioned, is notoriously inaccurate. Confirming the value of this technique is ever important, and we will have to make a systematic effort across the globe, across different units interested in this to make sure that we understand what it means to optimize and standardize our operating procedures and to confirm the clinical usefulness of this practice in our patients with liver disease. I thank you for your attention.
So thank you so much. I share the line to Professor Arciriacono, and I call the next moderator, Amrita Sethi and Michel Calais. Thank you.
Thank you, Skalk, for this fantastic lecture. Thank you very much. We can discuss tomorrow during your procedure. Yeah, so now we can move to our first connection from USA. We connect to the Orlando hospital. I think that there is Shyam waiting for us. Shyam, can you hear me?
Yes, Paul. Very good. Good morning.
Sorry for the delay of this connection, and thank you for your patience, to be so patient to wait for us. You can go ahead with your first case.
So I'm going to present this case to you. It's a 71-year-old patient who has a 2-week history of pancreatitis. Patient has been in the ICU. Patient is positive with an elevated Y count respiratory rate. Patient has been febrile, but now is only tachycardic and is not having a fever. The CT scan, as you can see, shows a CT severity of index of 8/10. This is acute necrotizing pancreatitis with almost no gland left back. The fluid collection is not packing to the flanks, and the plan is to now perform an EUS-guided drainage using a lumen-posing metal stent. And the echondroscope being used is a linear Pentax EG38 therapeutic scope. So I've advanced the echondroscope into the stomach of the patient, and I usually go to the distal end of the stomach because I think for gravity, when the stent is placed, it provides much better drainage than when the stent is placed more proximally. On EUS view, we're going to show the EUS view. You can see that the collection is about 13 to 14 centimeters by 10 centimeters when we measure. There's necrotic debris, and I don't see any residual gland. One can argue and ask, why not place a plastic stent? Because the stent is going to be left indwelling. And the reason that a metal stent is fewer over a plastic stent is because the procedural duration is shorter, particularly in a patient who's in the ICU, who's intubated, and who's septic. Otherwise, there's no difference between a lumen-opposing metal stent and a plastic stent based on all 3 randomized trials, one from our group and 2 studies from Europe. So I'm using a Boston Scientific Axios, hot Axios stent. This stent is 20 millimeter in width, and then the saddle length is 10 millimeters on the scope. So now we're going to anchor the stent to the echondroscope. And the first thing that you do is to advance the tip of the needle just a little bit outside the scope. So Stephen, we need to show EUS view on the big screen and endoscopy on the small screen, like a PIP. So with the scope in the distal stomach, which I think is the most ideal location for drainage, I'm going to identify a good spot for drainage. So anyone who's assisting me with the procedure has now connected the cautery cord, and you can see that it's very close to the transducer with almost no space. So this is a pretty good location to drain the collection. I don't see, I think it's just a flow problem, but I don't think there's any vasculature along the path because it's pretty clear here. So this is a good window. The distance is about 2.5 centimeters. So I released my, I unlocked the hub. I'm now advancing the needle pretty close to the transducer. It's come out. And the thing is to make sure that you're not deploying it on the proximal stomach because it becomes a problem if you deploy it proximally. So this location is pretty good for me. So now you can see the needle. I'm going to use a vertical elevator so that I'm not going in a tangential direction.
Hi, Shyam. This is Michel. Can you hear us?
Michel? Yeah.
Yeah. We have a little bit of an issue, hearing you clearly. Can you check your connection from your side?
You mean the audio?
Yeah, the sound doesn't come very clearly.
Okay, fair enough. How about now?
If you can have your team check on the sound.
They're doing it now. Can you tell us if there is any improvement in audio?
That sounds better, Shyam.
Okay, I think we had probably decreased the sound too much. So you can see, Michelle, I don't think there's any surprises here. I'm about 50 centimeters in the stomach, and I've lined the collection. I have a 20 millimeter axial stent, and I'm looking for a good angle. I think it's going in a tangential direction on the top. So I'm going to just come down a little bit and find another location so that I don't have any problems. And there's a tube in the patient, as you can see, for enteral nutrition. So I pull back again, and I think this is a pretty good look.
Shyam, can you hear us?
Yeah, very well, Amrita,
Great.
I can.
So question for you, is your plan to do multiple sites, and does that play a role in which you're choosing?
Amrita, I think a multiple site technique that we have described earlier was actually excellent for plastic stents because we needed them. But I think with a lumen opposing stent, the concept of multiple is not, doesn't hold true anymore. I think we can pretty much drain very comfortably with these stents. Unless the collections are non-communicating. I think I'm in a good location. I'm just going to go ahead and do this procedure.
Sounds good.
So you can see that the introducer set is now inside. We will now remove the electrical cord. Unlock the safety mechanism, and I'm going to first deploy the distal flange. The distal flange is deployed. I pull the stent closer so that I can deploy the second one. I'm locking the mechanism, and I'm deploying the second stent intra-channelly, and now I unlock and I gradually push it an endoscopic deployment of the stent.
And then do you plan to dilate and or place a double pigtail stent?
You can see it's already draining, and the stent is now coming out, and there is a rapid drainage of fluid contents there. So I think once the dust settles, I think you will have a much better view. I've pulled out this so that I can lock the biopsy channel and show you a better view on what has happened. So a couple of things, take-home points will be, when a luminopoussing stent is deployed for a fluid collection, not to be in a hurry and then to terminate the procedure. It's important to aspirate as much as you can. And then we generally have the habit of putting a tandem or a ERCP cannula through the lumen of the stent and then irrigate it profusely, because as much solid debris as you can remove during the initial procedure makes recovery faster. It's not aspirating very well. I think it's just rapid drainage of cyst contents that that you're not getting a good view to see the stent. I can see the stent in front of me, but it's just draining so rapidly.
Shyam, when would you place a double pigtail through the lambs?
So that's a good question, Amrita. I never do it. The only time I place a double pigtail plastic stent is partly based on one of the papers that Michelle had written, because it changes the axis of the stent in a bile duct. So when we drain a bile duct, and when you place an axios, it goes horizontally, and then the rate of jaundice resolution is quite slow. So I always put in a double pigtail plastic so that it changes the orientation. When it comes to a fluid collection, I never place a a plastic within a stent, because the whole point of doing this procedure is the elegance and the quickness with which this procedure can be completed. I don't think a plastic stent within a metal stent has any advantage. And I think last year at DDW, there has been enough data that has been presented that shows there is no advantage to that concept. I know that everyone wants to probably look at this stent. I'm sorry. I think there is just so much drainage that you can't see very well what's happening.
Shyam, can you hear me?
Yes,
Paolo,
I can.
thank you very much for this fantastic demonstration, and very, very quick, as you are always. Now we move to Ecuador, and then we will back to you in a while. Sure. Thank you very much for your demonstration.
We have an app problem.
Carlos, can you hear me? Carlos, can you hear me?
Yes. I can hear you.
Oh, great. So, shall you present your case? And welcome to Euro US. It's a pleasure having you with us. So you can start your first procedure.
History. He developed unintentional weight loss and jaundice 1 month ago. CA99 reported 250 international units per liter. Endoscopic ultrasound showed a 25 by 20 millimeter pancreatic head hypoechogenic lesion with main pancreatic duct dilation. EUS FMB confirmed pancreatic adenocarcinoma. ERCP with fully covered self-metallic stent was performed for biliary drainage. Patient refused surgery due to risk of complications. Proposal: contrast-enhanced EUS with deep flow imaging and EUS-guided radiofrequency ablation.
So hello?
Yes, Carlos, we can hear you.
Well, I would like
How are you?
to provide, just to show you, prototype of USAI for educational proposals. As you can see here a little bit, I will take just few minutes, few seconds. You can see here how the structures of AI are recognizing very well. And it's part of the future. This is the third generation of this AI. So we have faster recognition, and I want to say thank you to Daniela Tabacelli, because during the fellowship, she works a lot with us in this new model. So this is part of the future, and probably at the end of the year, we will start the FDA submission. Probably next year, we will have this available in center. So just showing you a little bit how AI is working now in the US and the big steps. So I will go to my case. I want just my US image. So now we have a patient with a pancreatic adenocarcinoma, and we want to, we try to send this patient to surgery because this is a formal indication for surgery. This patient, I believe, is better to perform a surgery. But today we want to show you a little bit the mass. We are here. I want just the image of US. Solo quiero la imagen de endoscopía en grande. So we already do some DFI. I know that you are, we are late. So just showing you that the lesion doesn't perform any captation of the contrast, at least the microvascularization. There is not microvascularization inside, confirming that this is pancreatic cancer. So we start first results regarding pancreatic adenocarcinoma using more watts for radiofrequency, and I will use a little bit of contrast just to confirm that the DFI is correct. Un segundo, por favor. So we have here the mass in the head of the pancreas. This is a 2x2 lesion. And now I would try to apply the contrast. So in the future, I believe with the studies that we are performing here and other places, we will arrive to use just DFI to see this kind of lesions. I saw today Dr. Dietrich show a very beautiful case. We had a case like that a few days ago. So now I will do contrast, please. Yep. So now we do some contrast just to confirm. We already know that this is an adenocarcinoma, and that's good. The histology is already, I will pass my needle. So we'll start to see the contrast, and you see there is no captation. There's some captation here, but this is for inflammation of the stent that the patient had already. But you can see here, the lesion have a captation of the peripheric area similar to the DFI, and this no captation of contrast, okay? So I will start to do my therapeutic now, and I will use a 19-gauge needle from StarMed, from Day1 Medical. And the difference from histological type is very important because regarding this, you will apply more watts or less watts. And what we saw in your first series of 30 cases, sending to DDW last year, I believe. Yes, last year. So in big masses, pancreatic masses, adenocarcinoma, we had a reduction of 50%, and some patients that we recovered to send to surgery. So, and the difference from other series is that we use more watts. It means we use at least 50 watts. In this case, this lesion is small. We didn't have pancreatitis in our first series. In this patient, there is a small lesion, so I will pass my needle, and I believe just with one shot, we will destroy the complete lesion. So I always start from the distal part. You can see here my needle. And then I go, I remove my needle and start to doing in the other kind of lesion, trying to cover the whole lesions. And we do as protocol always, in this case, we apply just 40 watts because the lesion is small. But you can see here, we start to see white. It means the hypoechogenic lesion becomes white, and it means we are doing a good job. So I start to remove slowly the needle, and I can continue to remove, until I complete the whole lesion. You can see here, okay? So it's very important to see the mucosa here, wall, because sometimes if you burn, you can do some perforation. So try to avoid this, okay? I will another pass.
And
in
Carlos,
another part of the lesion you can see here very well.
Carlos,
and
it's
again,
Amrita here. Are there different length needles in terms of the ablation zone?
Excuse me?
Are there different length needles in terms of the ablation zone? Or it's all one needle for all lesions and you apply it in different areas?
It's just one needle, my friend. Until now, 19-gauge needle. And the treatment is very good. You can see.
Yeah,
10
Amrita,
millimeters of,
I can tell you that there are needles from 5 millimeters to 1.5 millimeters actually in the, with the probe, active probe that you can use.
So I believe I already finished. So when I know that I finish, when my lesions become hyperechogenic. So a small lesion not need a lot of or a big treatment. Sometimes when the lesion is bigger, we can take more time because we need to pass in different areas. And the most important is to the whole lesion become hyperechogenic as you see here. So I already finished. I don't know if you have any question.
Yeah, so Carlos, you've done 30 cases so far, correct?
Excuse me?
You've done 30 cases so far?
Yes.
Okay. Any adverse event like biliary obstruction, PD leak, abscesses?
No abscess. We had some bleeding in 2 cases, I believe. And it was because at the beginning, because we applied more watts, we didn't sew very well the wall of the gastrointestinal wall, you know. Moreover, if you are in the bulb and the duodenal part in the bulb, so you can burn and you can burn some bleedings. There is reported also perforation. We had one perforation, but also because of the mucosal, you know, damage. But it was an operator problem, not because of the radiofrequency. So nowadays we don't have more this kind of problems because first we always evaluate with E-flow if there is any vessel, you know, because the radiofrequency can you know, damage some vessels. So it's very important, and moreover the vessels that are very superficial near to the gastrointestinal wall. And second, always seeing that when it becomes white, not apply more because you can burn the gastrointestinal wall.
So
Okay.
you're not using a specific time, because I believe that generator is also
No.
temperature controlled. It turns off if the temperature turns too hot, no?
No time,
Okay.
because I read a lot of papers regarding the time applied, and I believe that the first studies performed and also in neuroendocrine tumors, it's because they use it less watts, less power. So when they use less power, you need to put more time. You need to use more time to become wide, the lesion. But when you use 40 to 50 watts, it depends. Normally I use in adenocarcinoma 50 watts. In this case, just 40 watts. It's not necessary. When it becomes white, it's destroyed, the tumor. That's why this is the best signal that you will have, and doesn't stay like too much time because you will have pancreatitis or other kind of adverse events.
Carlos, and Paolo, can you comment on the fact that there are data showing that when you have the bubbles and you have this hyperechoic image that you so brilliant show us, is not really true that there is necrosis. And some groups usually stay for a while in the stomach or in the duodenum in front of the lesion in order to see when the bubbles comes away to perform a second treatment, just because we know from other studies performed by radiologists that the bubbles are not really a sign of real necrosis. What do you think about that?
Well, I believe you depend again, the power that you are using. We know that from radiologists that they said that sometimes there is not necrosis. What I believe is there is some necrosis because the heating of this probe is very fast. When you compare with microwave ablation, this heating is so high and so fast. So it's very difficult that you cannot have necrosis. So it is true that we need to do a second or third treatment sometimes in some cases because of there is still some tumoral cells. And it will depend also on the necrosis area and the diminution of the size of the tumor. So we applied here 2 months of treatment. We perform a CT scan and we see if the tumor diminished or there is a still tumor, we perform a second treatment. That's why many of these patients we send first to biliary drainage by US, guided by US, and not with a stent inside because we can come back with the oncology department to do a radiofrequency. But the results that we have in adenocarcinoma, 50 watts, are very interesting. And we need more large multi-center study to evaluate this.
So usually after this first treatment, you wait for 2 months.
Yes,
did you
8
understand?
weeks.
And in how many cases did you perform a second or a third treatment?
In around 20%.
So Carlos, we have a few questions from the auditorium here. The first question is, do you see this technology going from palliation to neoadjuvant?
I believe yes.
Okay. So when do you think it's going to happen?
What we are looking here is oncologists are believing more in this technology now, and they are sending and working with us together. Initially, the first study that we performed here was for patients that doesn't have any kinds of, of chemotherapy or because of other kind of conditions of the patients. And the reduction of the size of the tumor was very interesting, and the survival was around 18 months. So this is without chemotherapy. What we saw is also that in metastatic patients, it's not necessary because this will not change the quality of life and the life expectancy of the patients in patients with metastasis. But in patients with local advanced tumor, that for sure will change the rules regarding that we can recover some patients. We know that the immune system also have a role here with the radiofrequency. I really don't understand very well why the immune system becomes different after radiofrequency, but there is some demonstration for European group that it also affects this and have good results. So I believe we will recover patients for surgery for sure, and patients without metastasis, this will be the next formal indication of treatment as a palliative treatment or as a chance to recover these patients for surgery.
So Carlos, just to resume your idea and your trial, at which level of the treatment of this locally advanced patient without metastasis you suggest to include radiofrequency ablation? So at the first diagnosis, together with chemotherapy, after chemotherapy, before radiotherapy?
Before chemotherapy. You need to start before chemotherapy, and then you can do it. There is not contraindication. I didn't do it any case for the moment that the patient has been under chemotherapy, but I am afraid that if you do it during chemotherapy, the patient immune system will be down, and we can have some kind of complication like abscess. There are a lot of reports from European guy and radiologists also that some patients perform, are under chemotherapy, and after radiofrequency, they perform abscess in the liver, for example. So we didn't have any abscess until now, and I believe it's because we always perform the first treatment before chemotherapy, before start chemotherapy.
This is very interesting because, on the other hand, we, from our center, we have published randomized controlled trial, not with radiofrequency ablation, but with cryothermal ablation in patients with local advanced pancreatic cancer, together with chemotherapy versus chemotherapy alone. And unfortunately, we didn't see any benefit in survival. We have seen benefit in reduction of the tumor, of the lesion, but unfortunately no benefit in survival. So we are actually discussing, and this is why I ask you, when to perform the treatment. Where is the time, the good time to perform the treatment?
I believe this is a hypothesis. This is not, we, by protocol with the oncologist team, we perform before the radiofrequency, and we just follow up the patients. And in some cases, they had a second or third radiofrequency. Moreover, if the patients have more than 6 months, of survival and reduction of tumor, and there is still some kind of tumor, so we try to destroy the tumor. So this is a palliation. This is palliative treatment. And what we see is that those patients without chemotherapy, radiofrequency can help a lot, I believe, increasing the survival.
So thank you very much, Carlos. I know that you have already prepared another case for us. I do not know if you want to leave from this room and pass right to the other room. So we can wait for you 2 minutes in order to let you start the second procedure. Yeah, we are lucky because Carlos has a huge endoscopy, and they can perform and prepare the cases very, very quickly from one room to the other. So,
Paolo, I have a question. Would the presence of a metal stent affect the settings at which you would use, or be any type of contraindication? Because Carlos had mentioned he would do EUS guided. I don't know if that he meant hepatogastric.
With the monopolar probe, you can determine the conduction of the heating through the metal stent. So you should be very careful not to treat very close to the metal stent. So I think that Carlos is ready to present the second case.
Okay, case number 2. An 84-year-old male with pathological history of type 2 diabetes. He developed this and mild abdominal pain 2 weeks ago. Labs reported a white blood count and serotonin 99 normal values. Alkaline phosphatase was 409, gamma glutamyltransferase was 525, total bilirubin was 50 milligrams per deciliter, with a direct bilirubin of 11.18. Amylase and lipase were 59 and 117 respectively. MRI showed dilated common bile duct with periampullary stenosis and a dilated main pancreatic duct. EUS showed severe main pancreatic duct dilation with mural nodule. ERCP with biliary plastic stent was performed for biliary drainage. We proposed a contrast-enhanced EUS with deep flow endoscopy and the potential use of confocal endomicroscopy.
Hello?
Yes, we can hear you, Carlos.
Can you hear me? So we have this patient now with some important dilation of the main pancreatic duct, but I also have in the body, as you can see here, I take some pictures before, to go faster, but there is some dilation of the secondary duct. So I believe we have a mixed IPMN because of there is not lesion in the head of the pancreas, and we have this lesion here. You can see here. So we put just to do faster. We put a small 5 French stent quickly because I want to do a pancreatoscopy and see inside what is going on, because this patient will lose a lot of weight. The serum markers, tumoral serum markers are normal, but this patient have this lesion here. You see here, and we don't know if this is a mucus or this is a nodule. So I already do some DFI evaluation. So you can see there is not captation. There is no captation. And I will use now, so you can see the nodule there, and there is no captation. There is no microcirculation. So probably this is just mucus, but we need to evaluate because we really don't know. I will use contrast in this patient now. Vamos a pasar el contraste, por favor. Just to see if there is any captation of the contrast, and then I will go inside. So we pass the contrast, and we are waiting. So contrast is arriving. So what do you think, Michel?
Well, I mean, I'm a little bit disappointed.
No captation, huh?
Yeah, I'm a little bit disappointed by the captation.
There is no captation, huh?
Yeah.
So I believe the DFI will be the future, huh? But so for the moment, it's very interesting, and I want to go inside to see and to evaluate because I believe.
Carlos, don't you think that there is a small lesion right here, just above the pancreatic duct? Because when you have performed the injection of the contrast, there was this small area that you show now that was not uptaking the contrast.
Yeah, maybe.
Yeah.
Yes, this is what I want to do, is to see inside, because I believe there is two kind of situation in this patient. So one, there is already a cancer inside, and this is why the weight lost, or just because of this is mucus, and it's just because of the IPMN and bad secretion, pancreatic secretion. So I will change my tube now, and I will do a pancreatoscopy with a 9 French cholangioscope. So I will start to pass my tube, and I already perform a small, a sphincterotomy, not small but bigger, and I put a plastic stent just to go faster with the case and don't lose too much time.
When did you do that?
When? Today.
Yeah. Okay.
This morning. Before being with you.
Okay.
But in general, are you always performing sphincterotomy when you're performing pancreatoscopy or cholangioscopy?
Yes. So there is inflammation because I necesito sacar el. Bueno, empecemos por aquí. So I will. I will try to pass my guide wire inside and recover the stent faster and then to perform a sphincterotomy. Okay. Ojalá que la punta de la guía. Retira. Okay.
Carlos, when you saw it this morning, did it have the typical appearance of the fisheye that you might expect given the EUS findings?
I can't listen to you very well.
Amrita was asking if it has an appearance of a fish eye.
No escuché. Alguien que me repita.
Okay, no fish eye.
No. Retiremos primero. Dame una asa. I will remove and I will go inside. So what was the question, Michelle? I have a very bad...
Yeah, so Amrita was asking if when you did the ERCP this morning, it had the appearance, the ampulla, of a fish eye.
Ah, no.
Okay.
No. And it's very strange because not always is present this fish eye. Cierra. ¿Tienes? Listo. Okay. So now I will do a sphincterotomy of the pancreatic duct, and then I will pass cholangioscope. Okay, empuja la guía.
Can we see the fluoroscopy?
Yes. Fluoroscopía, por favor. Ok, empuja. Inyecta. ¿Podemos ver la fluoroscopía? So I will cut now. And I will pass okay. Empuja. So I will pass a 9 French cholangioscope to do a pancreatoscopy. We are trying to publish our first series with this 9 French and also the 7 French cholangioscope. With the 9 French, we didn't have any pancreatitis. So probably in the future, 9 French will be the indication, formal indication for pancreatoscopy in some cases, as this one. So now I'm passing, okay. I believe Clever is too slow, my technician. What do you believe, Michelle?
No, Clever is amazing.
No, he is too slow.
I'm a big fan of Clever.
He made me put angry yesterday, huh? I went to anger management because of him.
Yeah, because you develop an HR service in your institution.
Yes. So now I am passing the cholangioscope. I don't know if we can see the image. Necesito la imagen de... So this is the 9 French cholangioscope from Mycotech.
What is the working channel of the cholangioscope, Carlos?
1.2 millimeters, similar to the spyglass. The difference of the spyglass is that the spyglass have 10.5 French. 10. So we can pass normally we can pass
Just for the auditorium, what is the working channel of the 7 French cholangioscope?
Oh, the 7 French is, let me see. ¿Cuánto? 0.8.
Okay.
So I can pass here, you see. I need to do a dilation first, I believe. Préstame un dilatador, por favor.
Can we see where you are on fluoroscopy?
Yes, I am in the head.
You're literally at the entrance.
Yes, I'm por allá. So I will do a small dilation and pass the nudge.
So do you think that may be stricture from the lesion that Paolo had pointed out on the EUS?
Yeah. Empuja. Empuja, 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 empuja. Préstame por los lados el dilatador. Sí, presta. Así.
But interesting that the ductal mucosa
retira.
didn't look.
¿Esto qué es? ¿De vía biliar? Ok. Ok, retira. Ven ahí. Sí, déjala ahí. So I will pass laterally because I want to go faster a little bit.
So in terms of flexibility, how does this cholangioscope compare to spyglass?
In terms of what?
Flexibility.
Flexibility. Well, I don't know how to say. I think spyglass is a little bit. Pásalo por acá. I think spyglass is a little bit hard. The flexibility is really similar. A little bit more flexible. This one.
Okay.
But the most impressive is the quality of image, even of the 7 French. It's a really high quality image, and as you will see in a few seconds, this is an amazing quality of image, and that will improve a lot of things regarding what we are looking during cholangioscopy or pancreatoscopy. Spyglass have a very good image also already, you know, but this already have a very good image, better than the spyglass. I never saw. So now I am here. I will do a small dilation. Dilata. So I'm doing a dilation now.
And I assume you've given the patient indomethacin and antibiotics?
Not for the moment. Infla. Not because this patient already have a disease in the pancreas.
Okay.
So the risk of pancreatitis after manipulation is really low. And if the patient have cancer, I believe also will not. Okay, let's infla. So now we pass my cholangioscope.
Pretty tight.
And Carlos, you've published on the AI platform that you have for cholangioscopy. Would that be like a software enhancement for either of the scopes, or is it specific to?
No, it works with any scope. So we do a live case of pancreatoscopy the other day, similar case, and AI already also work in this kind of lesions in the pancreas. So it's very interesting, and I believe in the near future we can use for both AI, you know, for pancreatoscopy and biliary tract. So we will see now what is going on inside. That is, for me, the most important now. I need to see what is going on with this patient and to see if that was mucus or was a nodule. I believe it's a mucus, but we need to confirm. So now we pass. Now I am inside the pancreas. So we see very well the pancreatic duct. I don't see a.
Can we have the pancreatoscopy view?
So podemos ver la imagen del páncreas. And I believe with the 7 French cholangioscope will be also really nice to have a good view of the pancreas. You see mucus here?
Can we see where you are using fluoroscopy?
Yes. I am in the body of the pancreas now.
Oh, you're pretty deep.
So no evidence of IPMN anywhere.
No.
It will be interesting on the way out to look at that stricture.
Yeah. So you can see some kind of inflammatory here, inflammation here. This is maybe trauma of the guide wire. So now I am in the head, very near to the exit. So I don't see any malignancy here.
Yeah.
No, that's.
And I don't see IPMN. Let me see very well. Maybe here.
Do you find this scope to be more stable in the distal bile duct and distal pancreas?
So this is.
This area is a little bit concerning, actually.
Yeah, this is where. Look. This is a secondary duct. You see?
Yeah.
At your right. So the main pancreatic duct is in the left, and this is a secondary duct. And here is. So this is the main pancreatic duct. So what do you think, Michelle? What do you think, Amrita?
I'm a little bit concerned about this area. There's definitely an area that is more stenotic.
Yeah.
So the question is this something that is extraluminal that you're not seeing it?
Yeah, probably.
Yeah, I wonder if, I mean, some of these changes might be because of the balloon dilation. But I would wonder about going back and performing FNA on that area.
The other thing you can do, actually, Carlos, I was thinking, I know you still have confocal.
No, I believe it's not necessary confocal in this case.
Really?
I believe we need to take biopsies, and I believe we need to take some biopsies. But what we saw was mucus. This is the area. This is the interest area. So I go a little bit AI, because AI is showing a little bit this is a suspected area.
What about confocal, Carlos?
Yeah, I believe I will use it here.
Yeah, I mean, you're right there, so.
Yeah, I'm right here. So we are changing to artificial intelligence. Préstame el confocal, préndelo. So
but the AI program that you have has been working mainly with the bile duct, correct?
was trained by the viaduct, but we start to see that also work in some kind of lesion like IPMN, and it was trained also by neovascularization. So this is why we are starting to look in what happened in the pancreas,
Yeah.
in the main pancreatic duct in some lesions, and we're starting to detect something, and so I will, we need to evaluate this in the future.
Yeah, I really think it needs its own protocol because we can't assume up front that anything we see in the bile are going to be similar in the pancreas.
¿Pasa o no pasa? No, 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 ya. Voy a pasar, espérate. So this is okay, déjame pasar. Oh my God. Okay, pasemos. Okay. Listo. Empuja. A ver, pase con focal.
Yeah.
Ya estamos ahí. So we have the fiber outside now. Le pasaron la fluoresceína.
I have to admit, I'm very curious to see what it's going to show.
You don't know what is, huh, Michelle?
I mean, I'm suspecting something that is pushing from the outside.
You are suspecting what?
I'm suspecting a malignancy that is giving you an external compression.
Puedo ver con focal.
So basically, the cancer
Focal en grande.
didn't start from the duct. I mean, we'll see.
I mean, certainly based on your features that you describe in cholangioscopy, there's certainly nothing concerning there.
Yeah.
I mean, this is one of those really good cases for confocal because it's going to allow us to see if there's inflammatory criteria or cancerous criteria.
Yeah. So now I have the confocal here. I don't know if pasó la fluoresceína or no. Maybe didn't arrive yet.
Yeah. So this is a good question. So, did you see any features of chronic pancreatitis on EUS?
No.
Okay, that's what I thought.
And you don't see any feature inside?
Yeah. So the big problem with confocal microscopy is that you need very, very good contact with the epithelium to have any kind of diagnosis. So that's going to be the issue here.
I'm trying to have a good contact. So let's see here.
So for people that are not familiar with confocal microscopy, when you inject fluorescein, a normal cell will take the fluorescein and will appear clear. An abnormal cell will appear dark. Very dark typically is a sign of malignancy. Gray could be, depending on the features, a sign of inflammation.
So I think there is a lot of fibrotic area here.
Yeah.
That's why I can see nothing at confocal, you see?
So this is a very important remark that Carlos said. Fibroses don't take the fluorescein, so you basically don't see anything.
So I believe there is fibrosis here, and I believe we need to take biopsies because I don't see any sign of cancer here.
Yeah. So you will see very dark cells that take glandular appearance, and we're not seeing this here. Yeah, we're not seeing that.
There is not vascularization.
Yeah.
There is nothing, and this is very wide to our image. I will try to go inside a little bit. Let's go to see here, normal epithelium.
Yeah.
What is going on? And then, you see?
Yeah.
Normal epithelium, okay? There is no criteria of chronic pancreatitis, okay? So And this area is with a lot of fibrosis, the area that we see here.
Yeah.
So I believe it's a fibrotic tissue. Why? I don't know. Or maybe it's a cancer here, you know.
Can we?
So can we look again at the area?
Yeah, can we look at the game? I think now the fluorescein really took over.
Maybe there was debris on the probe also.
I will try to see again. You see?
Yeah. Okay, can we see the confocal
Confocal, por favor, en grande. Confocal en grande.
Okay, can we?
You see?
Can we make it
So
bigger?
what tissue we can see, and here we cannot see. I think there's a lot of fibrosis here.
Can
and
we
I
make the
need to
confocal
take a
screen
lot-
bigger? Ah, here we go. Thank you.
Yeah, you have the confocal here.
Okay.
You see?
Yeah. Yeah, there's no,
And I
there's
am
no,
really,
no feature.
really near to the mucosa. You see?
Yeah, there's no features that is concerning here.
No features. Yeah.
So Carlos, you're showing us 4 new modalities: contrast, US contrast, the cholangioscopy with AI, and confocal. Where do you think this will all play out in the end? You know, will there be one that takes over everything else, or you think they're all going to continue to complement each other?
I think it's you know, complementary technology. It means DFI will replace contrast for sure. So now we can see the microvascularization, and there is no additional cost for that. I use confocal because we have here, and you know, and in some kind of cases, I was suspecting here that this was IPMN because of the dilation, but we see that you know, the pancreatoscopy showed that there is nothing. So probably if I just do it, the US, my diagnosis was beginning an IPMN. Now that I do a pancreatoscopy, I really take out this diagnosis, and I am focused now in this fibrotic area that probably is a cancer, but with a lot of fibrosis. So that's why we cannot see by confocal. So we need to take biopsies from this area. And la colangioscopía en grande, por favor. So from this area, from the fibrotic area, that's why I can't pass, even if I do a sphincterotomy from the main pancreatic duct. So colangioscopía en grande. Sí. And so I believe it's better to do biopsies here, a lot of biopsies, and wait for the diagnosis. I will less a small stent, because what we saw was just mucus or, you know, pancreatic secretion, you know, inside, and that's why the dilation of the main pancreatic duct. Yes.
Carlos, thank you very much for this fantastic demonstration of all these tools that we can use beside and on top of EUS. So then, thank you again. See you tomorrow. And now we move to Orlando, to the Orlando Digestive Health Unit to show the second case.
Ready?
Okay. Thank
Hello,
you.
Shyam.
Hi, Paulo. So we have a patient here with obstructive jaundice and has unfortunately a gastric bypass. So I'm going to just show you the endoscopic view. The challenge always has been that we don't want to go on the small limb side for placing your stent, and that is at about 50 centimeters. And I'm now withdrawing my echondoscope into the stomach, into the esophagus. The gastric remnant pouch is about 3 centimeters. So I'm right here, and I'm looking for some gastric folds through which I can identify the excluded stomach to inject saline and then to deploy a lumen-opposing metal stent for this patient. So that's exactly where we are. So I see some stomach gastric rugae here.
right there. And just before we started, I thought maybe I'll be able to find an area there to inject, but obviously I caused a little bit of a submucosal injection into the stomach, into the gastric wall, because I think I was not deep enough. And here I am, a little bit of resistance. I'm going to try to now irrigate this to see if I can find the gastric pouch. This was one of those techniques that was described by Michelle, actually, unless, there we go. So I'm going to try to expand the stomach so that we can gain access into the excluded stomach. And I don't think I'm making, honestly, much of a progress because, let me see, is it?
Yeah. Do you inject contrast at this stage, Shyam?
Into the contrast, into the gastric wall?
Yeah, I mean, once you're inside the excluded stomach with the needle.
Yeah, we do have some contrast, Michelle. Maybe instead of putting a lot of water, probably contrast is good. Can we get a contrast injection, Max? Huh? Just get a syringe with contrast, and then so that once we are there, we can then go for it.
It looked like you have a very nice target there.
Yeah, I think my window is a little small. I've retracted that needle, and I'll try to see if I can get a better area. I was hoping that I'll find some air, and you see there is the gastric. I can clearly see the rugae, and then I'm tracing it down. I think that is pretty.
Was the Roux-en-Y done laparoscopically or open?
It's open, Michelle. I think I have a reasonably good window there. Maybe can you please Doppler it for a second? I think.
So
maybe.
I've noticed that the open Roux-en-Y gastric bypass, there is actually much more opposition between the excluded stomach and the pouch.
Okay.
And you can see it here. It's like it's really completely immobilized against the pouch.
Yeah. See there, Michelle. I think my worry here, if I would do something, I can. I'm torquing my endoscope to find the gastric lumen. So there is nothing there.
Yeah.
Here, there is I see a path here. There is something here. I think I might get lucky here.
Yeah.
Right? I might lucky there. I think the needle is there.
Looks good.
Okay, inject some contrast, Max, please. Oh, it came out. Hold on. Ethan, can you maybe, it came out. Let's find the spot again. Hold on, not yet. Right there, Max. Right there. Don't let it move if you can. It's a magnified. Yeah, right there.
Yeah, it looks good.
Yeah. Yeah. Take the stylet out. Yeah, good. Excellent. And then let us see where we are. Fluoro, please.
So that's a very important moment because this is where you want to be in the lumen. It's very easy to do a submucosal injection against the stomach wall on the other side. So this is why this injection is very important. You can see very nicely some rugae.
Yeah, I think we are okay there, Michelle.
No, it looks really good. Really, really good.
And then we can take the injection out and connect the water pump. I'm going to hold on to dear life my needle and not move it because we need to inflate it and then get it into oops, it fell off, guys. Because you want to inflate it and bring it as close as possible to the okay, there we go. Because I think if we can't do this, then the procedure is anyway a failed procedure.
And you
Fluoro for 1 second. Let us see where we are.
This looks good.
It looks like something is going in.
Now, do you give some glucagon also to kind of like decrease the
eventually, Michelle, that is true. I mean, before we, after we inflate a little bit, yeah, that's exactly what we do.
Okay.
But Michelle, the gastric wall, did you see it's very thick on...
Yeah, this is what happened with those open Roux-en-Y. You have the apposition, but there's way much more scarring. I've noticed this. It's very annoying.
Because, you know, the flange is only about what, 10 millimeter, right?
Yeah.
So therefore, this gastric wall itself, Max, Can you freeze and check the diameter of the gastric wall layers there?
But it might be, Shyam, that if you continue to irrigate and
Yeah.
distend the stomach,
Yeah,
you'll
that's
find
my hope.
another spot that might be better, actually.
Agree, fully agree. It's about 15 millimeters as you come down more, too far. Yeah, it's about 13 millimeters. Let's say, I'm sure we can work this out. Unfreeze, please. And then can we get some glucagon 0.25? And then we will get a different window and find another spot maybe. Yeah, not bad. I think it's okay there.
It's already starting to open.
Yeah, we're making some progress here. So once the glucagon is ready, I think is given, we should get ready with the Axios, Max.
It already looks like it's becoming thinner in that area.
Yeah.
Maybe just collapsed folds.
So you intend to do this in 2 steps or in a single step?
So Michelle, I don't do suturing as you guys do. So this is only my first step. I do the easy part, and then we call our better endoscopist in the group, Dr. Bang, to come and suture it. And then she will usually perform a same day. Generally, she does a same day EUVS and ERCP. We have the slim Pentax EUVS scope, which we think is very well suited. It doesn't get hung up on the transducer, so she sutures it. She does a biopsy, and then once that is done, then we have, she will just pass a duodenoscope and put in a stent. I think I've got reasonably good fluid there. Fluoro for one time, just can give me a tap, please. I think it's all just going down beautiful. I don't think, is glucagon in? Okay.
Yeah.
Max, what do you think? Good to go? Can you... What do you think? Good to go? Because we don't have much windows. Stent open and ready. So we were doing a GJ yesterday, and one of the challenges was the rapid gastric emptying that was happening on the other side. We struggled for a while. Okay, let's go.
That's nice.
Yeah.
Okay, get it closer, please. Let's lock it next. Okay.
Which size
Okay.
stent are you going to use?
But size is 20, Amrita. We always put in a 20. Can you hold the scope here? So I'm at about 43 centimeters on the scope. I think we should be reasonably good to go. So getting the scope down. Can you give me a little bit of a better angle? Let us see. Rapid transit, huh? Okay, can we do that? Hold it right there. Okay. I'm ready. Okay, down, deep down. Lock it. Release the first flange. Am I too much out? I think I'm hung up there. Not too happy with it, to be blunt. Fluoro for a second, please. Okay, where is it? Are we too much deep down or deep out?
I think you can start deploying it. I mean,
I'm still in the channel, isn't it, Michelle?
Right within the
Yeah.
wall, I think.
I'm in the no man's land. See that?
Yeah.
I'm in no man's land.
So would you place a wire here?
We shouldn't do anything wrong here. We haven't deployed. So my suggestion is this. Let's hold it there. This was not built.
So, Shyam, Amrita actually was saying maybe you should place a wire since you already have access into the stomach.
Also, Michelle, can I just, my take is just pull the Axios out because it's not deployed and then just reinsert with the second Axios.
Okay.
Do I need a guide wire?
I think you have, I want to preserve that access just in case.
Okay.
It's a good access.
All
So
right,
you can
get a wire, please. Can we have a jag wire, maybe easier? Yeah, good. Usually it's not a problem, right? I mean, because it's pretty thin.
But because it's an open bypass, sometimes you have a lot of fibrosis there between two stomach.
And can we just see fluoro for a second?
Sure. Fluoroscopy, yeah.
You can use that to help see if there's any leakage of contrast out, which gives some reassurance that it's not an open perforation.
Fluoro, please. Okay. Okay, we have got wire there, Max.
Okay.
Okay, can we exchange? Hold the thing. Okay, just hold the track. Okay. All right, lock it and then lock this. Okay, let's exchange. Gentle, huh? Don't lose it off. Fluoro, please. Just make sure the wire is there. We're not losing. All right, good. All right, done. Not what we planned for sure. And now, just make sure the water is there. I would still give some glucagon, guys. Can we put the...
Shaim, your plan is to insert another Axios over the wire?
I would think so, Amrita, because my options are limited here, right?
Yeah.
Yeah, my options are limited here. My main concern, to be very honest, is this patient has got a pretty rapid gastric transit. So when I go down, if I don't find enough water, I think, see that, this is my challenge here. I don't find enough water there. Then you're in trouble. You have to go back with a FNA needle. You have to inflate more, and then you have to redo it because it's a point of literally no return. Let me see.
But you have a nice wire. You have preserved your access. So.
Yeah, and you've already created the fistula through the stomach wall.
So you should be able to put another Axios now.
All right. Let us see how this looks. Fluoro. No water there. Yeah, there we are. Can we get little? I think did you look at that wire? That wire is not good, Max. So the angle is a little screwed up. There we go. Okay. Now, can we get a better angle on this?
No, you have a lot of wire. So I think once you're about to enter, you can get some leverage by having your assistant pull you on the wire. You have a lot of
Fluoro,
wire.
please. See the wire.
Yeah, you see, so the wire is almost playing against you now. So you need your assistant to give you some tension.
Traction.
Yeah.
Yeah. The thing is, the Axios is always a tough stint. It's not like an ERCP catheter. Let me look on. I don't want to have too much of an endoscopic. Can we look here for a second to see where we are? Yeah. Hold it. Hold it. I want my wire straight, right?
Yeah, you have a lot of wire and you have a lot of leverage, so you need more traction.
I need more traction.
Yeah.
Fluoro, please. Yeah. So pull the wire. I'm gonna come back.
Can we have the fluoro bigger?
Yeah. Can we get fluoro bigger? Okay. There.
So this is what I'm saying. You have so much wire that actually you're pushing against the wall of the stomach. So you need a good traction, a lot of traction on the wire. You can sacrifice. You see now your angle is getting a little bit more friendly.
Okay.
So you need more traction, and then you should be able, just with simple traction, get into the stomach.
Problem, Michelle, is am I having enough water? Because I'm not seeing a lumen.
It's okay, because you have so much wire that you're gonna be able to advance the Axios deep into the stomach, deploy it, and then readjust. You have a lot of wire.
Some of that fluid now is extra gastric.
Yeah.
So you really just have to rely on the tension of the wire to slip you in.
Pull those stent, right? Because it's getting
I mean, you have a good fistula and you have a good wire, so all you need is good traction.
Okay.
Yeah, I like that angle. You see, that is a very good angle.
So the wire, I think we have the wire is still not in the best position, right? I mean, okay.
You still can get traction.
Okay. Eaton, can you hold the scope for me on this side, Eaton?
I think when you pulled the scope up proximal a little bit,
Yeah.
it gave you a straighter angle.
Yeah.
That way it wasn't pushing against
Plural.
the gastric wall.
So
Okay,
Yeah,
that,
yeah,
that is a
that's
good
nice.
angle.
That's nice.
That is a good angle.
let me advance it and see.
Yeah.
This will go straight and hold it tight. I don't need to create another fistula. So
Yeah,
this should be
I
able
don't
to
think
go.
I need to.
Okay. Pluro.
Okay.
Okay.
How deep are you with the axios?
But I have to stay a little closer.
Okay, but you're pretty deep, no?
Looks like.
Can you get some traction on the wire?
Can be some traction on the wire, I think so.
A little bit more, and advance a little bit more the axios. Like go deep.
I think I'm looking pretty decent here. Or
Yeah,
not?
but go deep.
Right. Hold it, hold the
Come
scope like
traction,
that.
traction on the wire.
Okay.
Some traction. Ah, that's not bad. More traction, because you see it's tenting against the wall of the stomach.
I
So
think
you
you
need-
still see the rugae sort of being pushed away.
Yeah.
One other option might be to put a balloon down and
Is
really.
it possible, instead of doing all that, to just get a FNA needle over the wire, inflate some water, and then stop fluoro?
I mean,
and
you've-
then one.
I think your angle need to be a little bit adjusted. Just if you pull some more wire, you should be able to enter with this device.
All right. Fluoro, please. I think,
So
yeah,
you see,
Michelle, I agree.
You
This is
see how
my
it's
one.
tenting against
Yeah.
the wall? Here. So pull some wire, pull some wire, pull some wire, more wire. You see how it's tenting against the stomach? Pull some wire so you can get a better angle. And then keep your angle by US. Keep that angle by US, because the fistula,
yeah,
you created it by US, so you need to keep that angle. You have to see that fistula while you're entering by US. Now, pull more wire. Pull more wire. You see the wire is playing against you because you have so much
Okay.
wire.
Can we?
Pull more wire. Pull more wire. Pull more wire. See, you have that
Is it coming?
little...
I don't think the wire is even coming, to be honest. I think it's very tight. That's why it's not coming. He's
but-
not able to move the wire.
Then-
And
then-
I can see the fistula track there, but I'm just worried. I'm very away from the gastric wall, and things are not very clear here. See there? I mean, I think I would rather suggest that we take the axios. I would rather go with the FNA needle over the wire. We should go deep inside, inflate some, put some solution into it.
So the
and
only
then do
problem,
it. Okay.
Shyam, is
But that is,
your gastric wall has traveled away from you, and also now there is a hole. So I don't know how well it will hold on to more irrigation, because we can see by the contrast in the air that it's leaked out. I wonder, we just had a case like this. I wonder if putting a balloon that passes easily over the wire that may pass through the fistula you created, just to kind of stabilize yourself, and then retract that a little bit, and then go in with the axios.
going with a balloon.
Yeah, like an extraction balloon or something that will pass easily, or even a dilating balloon, just to seat it well in the wire, straighten out the wire a little bit.
Okay.
And then
We
drag
can
the
do that. Let's
drag the
exchange.
gastric wall towards you.
The wire good? Wire is good, right? Yeah, we got too much wire there. That's the thing. Okay, let's exchange. Careful, huh? Wire has to be life-saving. All right, let's go. Okay, out. Let's get a cap on top of it. Come on. So the stent got deeply delivered in the gastric wall. It wasn't deep enough into the stomach. So that was a problem. So, all right, let's get the cap. Fluoro for 1 second. I think the scope position is horrible, guys. Fluoro. Fluoro. Okay. See that? It's in the stomach, but the tract has been dilated. Okay.
has this patient received antibiotics?
We will probably give a dose of Zosyn. We have not given any antibiotic yet, but we will. Good. So how does this help, Amrita? It's going to open up the stomach and give us a better angle with the balloon inside?
Yeah, I think just help to straighten the wire out, and also the opening in the stomach. I think that your axios was getting caught on that a little bit. So I think just passing something over, passing it deeply, helps straighten out your wires slightly.
Is there a choice of balloon, fluoro?
I don't know if anyone else
Max
has
has
any
given
comments.
me a stone retrieval balloon. I thought he would give me a CRE balloon. Hold this scope like this. I thought he would give me a CRE balloon because it's much more stiffer, but he's given me a stone retrieval balloon. Let me see how this goes. Just pull me in, keep pulling me in. Pull, 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 pull. Okay. I think I'm getting down. Okay.
So yeah, you need something pointy, some like a pointy balloon.
Fluoro. Okay. I think, and I agree with what you guys say. I think it's okay. Hold it right there.
Now you need something
Scope
pointy.
is bad. Yeah, I need to come back straight on that.
Yeah, I would switch to a CRE.
Yeah.
Switch to a CRE, right?
Yeah.
Do you have like a 6 millimeter or 8 millimeter CRE?
Yeah, we have a CRE, of course.
Yeah,
I think we are deepened, guys. Fluoro. See there, it goes in, but CRE.
Yeah.
I can see gastric, and I think we are where we need to be. 6 millimeter.
So the other thing, Shyam, how is the belly? I mean, do you need to decompress this patient? Like
No,
put a little,
very soft.
Very soft.
Very soft. Tummy is very soft.
I mean, we just literally, Amrita and I went to the same routine.
Yeah, see that? I can now follow this pretty well, Michelle. See that? I've got the gastric rugae, I can see well. My main concern is I'm going to be deploying an axios into a non-distended stomach.
This is not your fault. This is because of the scarring that was induced by
doesn't
the
matter.
open surgery.
I had a good opportunity, and the stomach was fairly distended. I think
So-
I
so-
underestimated.
So Shyam,
I'm going deep in. Fluoro.
So I'm going to tell you what I did in one of those cases. I ended up dilating, and in most cases, you're going to be able to get away just by dilating the tract. In other cases, I actually ended up using the cystotome, the 10 French cystotome.
Yeah, should we just deploy? But the problem is there's no solution inside the stomach. Can we inject some solution through the balloon? Do you think, no, the catch is, will it all leak into the abdominal cavity? Because if you fill the stomach, we already created a fistula. So the question is, what the suggestion is, just to deploy it into the stomach and then just make sure you deploy it outside. The challenge that we will have is we have got a completely collapsed stomach, right? Completely collapsed stomach. We'll have to bite the bullet. Fluoro? Can I go? The angle is pretty good see that? I can see the stomach there, there, right? So should we just release it, guys? What do you think? You think I should just exchange, maintain this position for...
I think the issue is just making sure that you can get the catheter, the introducer, into the stomach and not caught on the edge of the stomach.
Okay.
Yeah.
So
Okay, let's exchange. Get
doing
a
a
CRE.
quick dilation would be helpful.
Okay, sure. Thank you.
And then you have to use that angle by EOS and get a lot of traction.
Now G is holding that wire to dear life, so we'll get it. Fluoro, please. Okay, thank you. Okay, out, almost.
Yeah, this is great. You see, now you have just enough wire, not too much, not too little.
I think this is the second time we are having a problem with this GJ procedure. The last time we did it, it was sutured, and then when we dropped the EU was slim scope, the sutures came off. That was end of it. And then the stent migrated into the deepen, couldn't be retrieved, and the patient had a lap exploration to get it fixed. And this is our second time Okay, let's go.
It's an interesting day for GJs.
Yeah. Troubleshooting Lumina posing stent. This is a great angle by US, by the way. Just make sure you have the right amount of wire so you don't have any, you're not basically working against your wire.
Just what it does is they're so not used to deploying stents, right, without seeing on the other side. That's what. All right, let's go. I'm almost there, I think. Pretty tight. Giving me traction, right? Oops, see that? Don't let it buckle if you can. I'm not locked, okay? Just give me traction. Traction, Max. Traction, now I see what you guys say about the Axios will not go that easy. Yeah, right. It has to be, see that? Fluoro? Let me see. So, okay, let it come back. Yeah, it's hung up.
Yeah, you see, that's the angle.
Oh, not needed, because there's a track there. See, that's a problem.
Okay, so it's tenting.
Huh? Yeah, it's tenting.
It's tenting,
so
which means your fistula is not big enough.
Okay, there, fluoro. Okay, pull. See that? I don't want that angle either. I want to straighten this up right there.
Okay.
Yeah, there. Might be better. Fluoro. Buckling, guys. Okay, come back.
Yeah, it's not going through.
I think you'll
Right
have to
there.
use a cystotome probably.
Yeah. So you gotta use a cystotome here.
Cystotome, huh?
Yeah. With a cystotome is gonna go. I mean, unfortunately, those surgical stomach are
Okay.
extremely
So,
thick.
Oh, they were in the
I'm
US.
I'm just curious, is the tummy soft? So
What's
you
that?
got small bubble, huh? Tummy is soft. Small bubble loops are not seen here. I mean, we see the contrast that has passed from the stomach deep down.
Yeah.
I'm not seeing any obvious leakage here. Oh, there it is. Okay. I'm just wondering, should I just repeat it and find another tract?
Well, you have a very, very nice access here. I wouldn't give that a one up. I mean,
Am I just complicating my?
I mean, if the problem you may encounter the same thing because it's a very, very thick stomach because of
Okay.
that surgery. So I think, as I said, you tried dilation.
Fluoro,
I've
okay.
had some success with the 10 French cystotome. I would do that
Okay.
now.
Well, I think the decision points, similar to the case that we were in,
Yeah.
is has the small bowel defect been created?
What do you think?
Because
Should
if
we
it
just repeat it?
hasn't, then it's very similar to the case that we just
Yeah,
did.
but he's gonna still
That is the
encounter
wire
a
now.
very
See
thick
that?
stomach because of the open groin wide. The majority of edge we do,
Fix the thing.
we don't even realize it. They've done in patients that have laparoscopy, and the scarring is very minimal. But the open one are the ones that are the worst.
I think we should just
And
repeat it.
most of
What do you
our
think?
issue has been with those.
Max, let's repeat it. Okay, guys, we made an executive decision. We're going to repeat it. Take it out. And we will we will live by the consequences of our action. But I think we're just going to repeat it because we may have a better success. She's doing pretty good now. We haven't seen significant leakage or anything, and we may get lucky with it. Let's go quickly with the FNA needle again.
So
And
will you close the defect you've created in the gastric wall? In the
afterwards, yes, Amrita, I think G is going to go and suture this, and she will close it, yes. G, that's a plan, huh? All right, let's go. Because they're right, because we created a tract, and we pulled out an axios through that area, there's a good chance that there will be some fluid down and so on. All right, there we are. Okay, abdomen is soft. Okay, hold the scope there. We're going to get this right. Be gentle, huh? Okay, how many centimeters are we? Don't want to be on the jejunal side. Look on the gastric side. Okay, this is the stomach, right? Okay, let's go. And let's stay in this area. We are at about 44.
There's definitely biliary dilation.
Right there. What do you think?
Yeah. I just hope your fistula is tiny. That's it.
Shall I go? Just give me a little gap in the stomach. This is what they had, the problem we had before. Okay, let's put some sealing, okay? Okay, let's go. We fully agree with your concerns about the leakage and other things. Point very, very well taken.
I assume the patient gets some antibiotics, right?
Yep, absolutely. We'll make sure it happens. Can we have some glucagon, please?
It's good filling, though.
Okay.
Thank you. Huh? Yeah, much better, right? Yeah.
So Michelle, it has also been described to do a jejunal stick. When do you think it's beneficial to do jejunal versus the pouch?
Actually, this would be a good case for jejunal stick. I was thinking about that.
Yeah, it's going all the way down.
But then,
pretty much,
a one-step edge is a little bit harder. And
guys, I haven't seen any leakage yet. Maybe I'm being falsely optimistic, but probably I'm falsely optimistic because the whole flange came out. Are we ready with the second Axios? Good, G?
That's descending nicely, actually.
I know. Let's go.
Okay.
Let's go with the second stent, guys. We have to do a parasite after this. Hold the scope. Okay, get. All right, let's hold it, G. Ready? Cordon. Tight. Hold this nice. Okay, let's go. Axio settings. Okay, good to go. Distance is good. Close. Unlocked. Closer, G. Ready? Get closer. How's that? Okay, this is the problem I had the last time. See that? This is exactly what I had the last. Okay. Can I see the distal end of it? No? See that? It didn't go. So this is exactly what happened last time. Okay? Okay.
You're
now
in.
So, and I would
This is
just
exact-
make sure
we
to
got-
seat that as
we got-
deeply as possible.
Yeah, you have to advance as deep as possible.
So that you're almost pressing away the opposite wall of the stomach.
Okay. Am I? Okay.
Okay.
We are in.
Good.
I want to lock it. Release the second flange. Okay. Release it. Push. Oops. Let us see where we are. Yeah, there we are. Hold on. Yeah, there we are. So, what should have been a 5-minute procedure is 20 minutes, but we will deal with the consequences of the first thing. We'll go down, have a look. G is going to go and suture the stent, and then we'll probably close the defect on the other side.
So Shyam, thank you very much. It was really nice procedure because you have been able to solve a problem, and this is very important to be shown because you and your team have shown how calm you must be when you do this kind of therapeutic procedures and some kind of complication happens.
Yeah.
So always be calm and deal with the complication.
Paulo, usually things are good. But when you have people from New York City around you, there's always trouble. Even if they are in the room or if they are 10,000 miles away, they are always trouble. But thanks so much for your support and walking us through it. Thanks, guys. Have a good conference.
Thank you very much, Shyam. See you soon. Thank you very much. Very well done. So I think that we have finished our first day of live cases. So thank you very much for the heroes that already are in the room and in the auditorium. And see you tomorrow. We will begin very sharp at, I think, 8:30. So have a nice evening in Milan. Thank you very much.
This is not a good